Okay. Can you hear me now? Okay, welcome to Labor and Health Meeting, first interim meeting of this summer. I hope you all are having a good summer so far. Today's, at least where I'm at, today's the first day of summer. It's the first day we've seen the sun for a while. So welcome. We're not moving this meeting outside, however. First item of business, I want everybody to reach on their pocket or wherever they got them. Take your cell phone out. Don't look at me. Take your cell phone out. Everybody's in the room. Online, I don't care. Everybody take your cell phone out, hold it up in the air. LSO, you're off the hook. Okay, now hold it in front of you. On the side, there's a button that's off of silence, leave it live because we would like donuts tomorrow morning. Tradition has it in this committee that if the cell phone goes off during the meeting, that you buy donuts for the next day. So there's a daylight donut I noticed I passed on the way here. So if anyone would like to leave their phone on, please do so. If you don't wish to be called on a stop a daylight donut, please turn those off. Welcome. Let's go ahead with roll call of the committee, if we would.
Mr. Chairman, this is roll call for June 2nd. Senator Furphy.
Here.
Senator Hutchings.
Here.
She hasn't shown her yet. Oh, there she is.
Senator McEwen.
Here.
Senator Wasserberger.
Here.
Representative Brown.
Is he online?
I don't see him yet. Excused until we see him.
Representative Connolly. Here. Representative Flittner. Representative Hallinan.
Here.
Representative LeBeau. Here. Representative Ottman. Here. Representative Stibar.
Present.
Representative Worf.
He's probably slept and I know he's in town. I saw him in the motel, but he's excused for now as well.
Co-Chairman Wilson.
Here.
Chairman Baldwin.
Here.
Mr. Chairman, we have a quorum.
Thank you very much. Okay, this morning we're going to start off as one of the notes that you see Senator Hutchings on, she'll be on and off. She's had a number of procedures. She has to get up and do some exercises and things through our meeting. So if you see her up here and disappear, that's why. Wave at her when you see her. Okay, if you look on our item of agenda, the first thing Mr. Hansen has shown up many times on our schedule today. Welcome. Okay, go ahead.
Mr. Chairman, Co-Chairman Wilson, Stephen Johansson, Director for the Health, pleased to be with you for 2 days on the agenda, but as you'll notice, it's my name or designee, so I'm going to rely on that designee option quite a bit. Our first agenda item with an overview of state services for maternal and infant care. Obviously, we could spend hours and hours and hours going through all of the detail of the various programs and components of those programs that might have services or funding for moms, babies, kids, et cetera. So we provided a very general overview in the presentation, and we'll get into more detail as we go through the agenda with other types of maternal and child health issues, postpartum coverage and Medicaid, those types of things. Mr. Chairman and members of the committee, I was going to take this opportunity to introduce you to a couple of my staff that I have here in person. We also have staff throughout the day that will be joining virtually should you have any questions or we need to have more detailed expert answers. To my left, we have Franz Fuchs, who you know well, our Chief Policy and Data Analyst in the Director's Office of the Department of Health. And I want to introduce you this morning to Garrett Catlin, who is to my far left here. He has been with us for about 5 or 6 months, and he is our Department of Health Policy Research and Evaluation Fellow. We got Garrett to come to the Department of Health shortly after he graduated from University of Wyoming, I believe with a master's in statistics. Garrett can correct me if I'm wrong there, but he's quickly becoming a really key resource for us in the director's office, great analytical capabilities. And we're throwing him to the wolves this morning to give him some opportunities to provide you some overviews and testimony. So be as hard as you want on him. It's good experience. But in all seriousness, we're very thankful to have Garrett on the team. And with that, I'll hand it over to him to provide you an overview on the first portion of the slide deck that we shared with the committee for state services for maternal and infant care. Garrett, I'll kick it over to you.
Thank you, Director. Mr. Chairman, again, my name is Garrett Catlin. I'm the Policy Research and Evaluation Fellow for the Department of Health. As Stefan kindly pointed out, I got my degree in statistics, and believe it or not, public speaking was not part of that, a whole lot of it. So bear with me as we go through this. But yes, I'm going to be presenting on the state services for maternal and infant care. And so we're going to just start off here with a summary of kind of our primary programs. So first off, we have the Medicaid and CHIP. And so basically what these programs do is provide health insurance for coverage for pregnant women at or below 154% of the federal poverty level. And also health insurance for newborns and children at or below 200% of the federal poverty level. We also have Women, Infants, and Children program, the WIC program. And what this does is it provides food, formula, nutrition, education, and breastfeeding support. And then low income mothers, so pregnant through about 1 year after of breastfeeding, and children under 5 who are at or below 185% of the federal poverty level are eligible for this as well. And then finally, we have some other public health, maternal and child health programs, such as infant home visitation, newborn screening, children's special health. As for Medicaid benefits for pregnant women, again, the initial eligibility is at or below 154% of the federal poverty level. Once eligible, coverage is continuous, regardless of changes to income or household composition through 60 days postpartum. Medicaid coverage for pregnant women includes inpatient and outpatient hospital services, medical, pharmacy, dental and vision, but this is limited for individuals and I guess mothers over 21, and there are no co-pays or other cost sharing. And then as far as the Medicaid benefits for newborns go, children born to a Medicaid eligible woman are automatically eligible for the first year of life. Medicaid coverage for infants includes much of the same, so inpatient and outpatient hospital services, medical, pharmacy, and dental and vision, and there again are no copays or other cost sharing. So continuing, Medicaid benefits for newborns. Many of these children transition to Medicaid or CHIP after eligibility determination following 1 year of that automatic coverage period. And then after this point, eligibility for ages 18 and under is based on household income. So if a child is between 0 and 5, they need to be at or below 154% of the federal poverty level. Between the ages of 6 and 18, that is at or below 133% of the federal poverty level. And then for MCHIP, that needs to be at or below 200% of the federal poverty level. So next, we're going to go ahead and take a look at some enrollment numbers. And as we can see here, you might notice this drastic spike in enrollment, but really what's happening here is we've exchanged 6%. We have a 6% bump in federal funding right now, but what we're trading off for that is we can't disenroll members. So you can see that this number is continuing to rise, but that is just because we're not disenrolling members at the moment. But you can also see then on the right-hand side, we have this per member per month, which is exactly, which is about how much money we're paying on average per month. And we can see this actually declining after COVID kind of hit. And that is also because now that we're keeping these women on, we're not disenrolling them. Usually that cost goes down significantly after after postpartum. So that is kind of what we're looking at here.
And Garrett, Mr. Chairman, if I may interrupt, just to provide some context, and you'll see this again in later presentations, members of the committee, when we talk about policy options for postpartum coverage and what we've been asked to present on potentially extending that and what that option looks like. Just to clarify, part of the rules from CMS for Medicaid programs during the public health emergency, which we are still in from a federal perspective, is that Medicaid programs across the country cannot disenroll members. So you've heard that over the past couple of years that we are not disenrolling people. So if you look at our reports, if you look at graphs like this on certain populations or eligibility categories, that enrollment has drastically increased since 2020 because we are prohibited from disenrolling folks who normally would churn either on or off the program, either losing income eligibility or some other categorical factor that qualifies them for Medicaid. This is really why you've seen enrollment grow. And we, as Garrett mentioned, we do have an enhanced federal match during the public health emergency, which recently got extended for another quarter. And thankfully, we haven't really seen the kind of uptick in utilization in our Medicaid population that some other states have seen. So this is a good graph, very specific category of our pregnant women eligibility group. But you can really see that while the enrollment has significantly increased, as Garrett mentioned, average cost has decreased. There are some nuances to that across the Medicaid program where we have seen utilization increase, but en masse, we haven't seen a huge run on the bank, as it were, with utilization and thus reimbursements. So wanted to provide that context. Garrett, please proceed.
Thank you, Stefan.
Mr. Chair, quick question.
Sure, go ahead.
What's the acronym IBNR?
So, Mr. Chairman, Representative Connolly, INBR stands for incurred but not reported. So you can think of it as kind of a claims lag. So essentially, we know that our services are being utilized, but we don't have the actual numbers for those yet. So it's kind of unreliable, and that's why it's highlighted in that red.
Thank you. Go ahead and proceed, Derek.
Awesome, thank you. So next we have kind of a similar kind of graph for the children. And so you can see again here, we do have kind of that consistent increase in enrollment, but again, this is much of the same as with the pregnant women where we are not disenrolling members. You can see also again, as before, that per member per month is slightly decreasing, but relatively consistent. Oh, yes. Enroll for the so for the women, infants, and children, so the WIC program, WIC serves low-income women who are pregnant, breastfeeding, or who just had a baby, and families with children under the age of 5. So WIC healthcare professionals, which are mainly nutritionists and nurses, provide quality nutrition, education, and services, breastfeeding promotion and support, a nutritious monthly food prescription or a package, and access or referrals to maternal, paternal, and child healthcare services. Current participants include 563 pregnant women, 544 breastfeeding women.
Derek, can you hold up 1 second? Oh,
You can.
she raised her hand. Go ahead.
367 postpartum women, so these are non-breastfeeding, and 1,601 infants.
And now I believe we have a question. Chairman Wilson.
Yes, thank you, Garrett. I just want to confirm for the committee's sake, the WIC program is 100% federal funds, right?
Mr. Chairman, yes, that is correct. So for the public health nurse, I'm sorry, oh, my bad. So for,
Okay. I believe we have a question online. I'm sorry because I can't see that in front of me. Senator Hutchings, go ahead, ma'am.
Thank you, Mr. Chairman. It appears I'm in back of you guys, so you can't see me. Early on in the slides, my question was why not have a copay or other cost sharing? Is that a federal decision, state decision? You would think with all the benefits, a mother or father would want some kind of skin in the game when it comes to receiving all these benefits. Thank you.
Looks like Franz may have the answer for you, Senator. Go ahead, Franz.
Excellent.
Thank you, Mr. Chairman, Senator Hutchings, Franz Fuchs, Policy Analyst, Department of Health. Medicaid significantly limits the amount of cost sharing that can be imposed on members at the federal level. So there are really strict federal requirements. And I think particularly for this population of newborns and pregnant women, it would be I'm not for sure. You really have extremely de minimis copays would be the maximum we could impose if we could at all. I know they're a little more flexible when it comes to lower income adults on the family care plan or other groups, but these groups are seen as particularly vulnerable. So I'd be very surprised if CMS allowed any cost sharing.
Thank you. Did that answer your question, Senator Hutchins?
Yes, sir. Thank you very much, Franz.
Very good. Without further questions, go ahead and proceed, Derek.
Sorry, Mr. Chairman. After WIC, we have public health nurse infant home visitation. And this is from Wyoming State Title 35, 27, 101 through 104. So the purpose is for pre and postnatal visits with pregnant women and infants to include health assessment screenings, assistance with breastfeeding, referral to community services and education. And this program uses evidence-based models from maternal early childhood sustained home visiting. There are currently 505 participants as of the 19th of May. And there's a capacity, so to speak, of 829. And this is because this total caseload is based off of the public health nurse workforce, and that is kind of the amount that we can serve at the current moment. As for other public health.
Sure.
I heard a voice down there. Go ahead. Representative Conley.
Thanks. I'm curious about the caseload and how is it distributed across the state? Do we see utilization proportionally, or do we see utilization in different counties, for example, more than others?
Go ahead.
Mr. Chairman, Representative Connolly, we can go ahead and look into that further. I don't have that information right in front of me unless Dr. Harris wants to step in.
And Mr. Chairman, if you're going to get me more information, I'm curious about if the capacity ability is based on whether or not there's a public health nurse in a particular county or area, or is it something else going on?
You guys have to tell me if Dr. Harris is there. I don't hear her. Nobody seems, oh, somebody's pointing at you. Dr. Harris, are you there? Would you like to address that question?
Good morning, Mr. Chairman, members of the committee. Allie Harris, State Health Officer at the Department of Health. Actually, and I hate to pass it on to somebody else, but Angie Van Houten should be in the waiting room, and she oversees the public health nursing program and may be able to provide you with more details.
Okay, I believe she's there. I can't see her yet.
Sorry for the delay. Chairman
Go ahead.
Baldwin and Representative Connolly. I'm Angie Van Houten, the Community Health Section Chief within the Wyoming Department of Health. And we have public health nurses across the state in every county that are performing the home visitation services. And so there are clients across the state. Obviously, in our larger counties, there would be more home visitation clients than in smaller counties. But we do have that in every single county in the state. Thank you.
Okay, let's go ahead and proceed. Go ahead, Derek.
Thank you, Mr. Chairman. As for our other public health services, we have newborn screening from Title 35 for 801 for metabolic or genetic diseases and major hearing. We also have gap filling, financial assistance to mothers and infants who receive care at a level 3 out-of-state hospital. So what that would be is like NICU, since we don't have any hospitals in the state with that. And what gap filling looks like is it covers things like transportation, copays, deductibles, and hotel charges would be kind of an example of what gap filling is. We also have in-person and telehealth genetic clinics. And what the purpose of these clinics are is to discuss genetic risks in pregnancy and also diagnose genetic conditions. And finally, we have prevention funding to counties for both substance use and suicide. So again, this is just kind of a sky view of it all.
Go ahead, Chairman.
Thank you, Mr. Chairman. Garrett, you may not know this one, but I'm curious on the gap filling financial assistance. What's the the budgetary source of that structure? I mean, is it a general fund pool that's generally overseen by the director's office or what?
Director Johansson, go ahead.
Mr. Chairman, Co-Chairman Wilson, no, it's not in my budget. I can safely say that, but I'll defer that to Ms. Van Houten to talk about where that funding source comes from. I believe it's a blend, but she can elaborate on that.
Welcome back, Angie. Go ahead.
Thank you again, Chairman Wilson. The funding for the gap filling program has come from state general funds in the past. It is a very small budget. And then personnel for that are funded through the Title V block grant that the agency receives. In the last budget reductions, we did reduce that state general fund. And so going forward, the program will utilize Title V block grant funds for that smaller budget as well.
Okay. Another question, Representative Connolly.
Thank you, Mr. Chairman. I was told to bring my microphone closer. I hope that works for you, Tim. Okay, I'm curious, with all of these programs here, are the Medicaid eligibility figures the same or are they different?
Mr. Chairman, Representative Connolly, maybe I didn't understand the question right. So you're saying for all of the populations that are served in these various programs, do they have similar Medicaid eligibility?
Correct. That's my question.
So I think the answer to that, Representative Connolly, is no, it would vary. So we have basically two buckets is the way I think about the programs that are presented in this presentation. One is Medicaid and one is public health. And there's a variety of services and programs within each. But the Medicaid eligibility is set pretty strictly on the financial boundaries. Now, a lot of those populations could and certainly are served by our public health programs, including public health nursing, home visitation, the services that we've outlined today. But it would vary because the public health programs don't have the same kind of financial eligibility standards that are in the other side of our house that our Medicaid programs do.
Further questions, committee?
Okay.
Oh, go ahead, Representative.
Thank you, Chairman. Director, I have a question and it's going back previously and I thought I better just answer it. So I want to go back to the topic of disenrolling members. You know, we got that 6% bump in federal funds. But what are other factors besides losing income eligibility? You know, you said income eligibility and other factors. What are those other like top 3 factors why you would disenroll somebody?
Mr. Chairman, Representative LeBeau, it's a great question. So I'll answer generally first and then specific to this population. As a reminder for Wyoming Medicaid, you cannot receive Medicaid strictly by just being low income. You have to meet what we call categorical eligibility standards in almost all of our programs. For example, our low income adults, which we call family care, the family care program, not only do you have to be extremely low income by the federal poverty level, you all take care of a child or disabled and qualify. General, that's one of some of the categorical eligibility criteria that we have specific to this population. In addition to the financial eligibility criteria that you see in the presentation, there's also a time limited factor. So postpartum coverage for pregnant women, for example, in our Medicaid plan right now, or in, I should say, in previous years prior to the pandemic, is 60 days postpartum. That's the coverage that Wyoming Medicaid offers to that population. Because of the public health emergency rules that were put in place by CMS, we are prohibited from disenrolling. So in many cases, our postpartum coverage has exceeded beyond 12 months and even longer since the pandemic began. So I don't know if that answers your question, but there's a variety of categorical eligibility criteria depending on the population in Wyoming Medicaid that would historically, prior to the pandemic, have caused you to lose eligibility, financial and other types of factors. We don't know when the public health emergency will end. It just got extended for another quarter, but we anticipate sometime in the next fiscal year that we will likely see the federal government rescind the public health emergency, which would trigger our old in enrollment and eligibility standards. So we will begin, once that happens, disenrolling members who are no longer eligible.
Chairman Wilson.
Thank you, Mr. Chairman. Stefan, I have a little bit of a down in the weeds question on this now, but something came to my attention earlier. Supposing that a woman were on family care Medicaid because of having children, and then for some reason custody changed, whether to the father or a grandparent or somebody like that. What's the legal trigger for maybe removing her from Medicaid eligibility? Is it a legal custody decision? And then she would, I mean, that's why I say this is a little bit in the weeds, but I'm just wondering whether, in family situations, there might be an inadvertent loss of Medicaid coverage to a low-income woman if it seemed more, better in that situation to have some other family members caring for the children. That would be, I would like to know what that is.
Correct.
And you don't probably, I guess I've stumped you. It's only 9 o'clock.
Mr. Chairman, Co-Chairman Wilson, it's a really good question. I think there would be enough nuance there that I would want to look into that, specifically with custody changes, how that works on the eligibility side. But I'll touch base with our Medicaid folks today and hopefully have an answer for you.
That'd be great. Thank you.
Okay. Oh, we got another hand. Senator Furphy. There, you can use mine. There you go.
Thank you, Mr. Chairman. We have discussed this in the past, but it comes up as a big issue. Women who are pregnant that fall in the gap, they're working mothers, a lot of them, single mothers. They're not Medicaid qualified, but they really can't afford insurance. What do we do with that population? They've talked to me and I don't have an answer. So I just thought I'd ask for your input, Mr. Director.
Director, go ahead.
Mr. Chairman, Senator Furphy, it's a big question. I'll answer generally and say, like you'll see today on some specifics and some kind of narrower policy decisions that we'll present to the committee. There are a variety of vehicles, both federal and state, to either extend coverage, whether that's in this particular category that we're talking about today, pregnant women and postpartum coverage, or what I believe you're referring to with Medicaid expansion options. Those are out there. It's not part of our presentation today, but happy to provide you with our Medicaid expansion report. And we can certainly today, if the committee wishes, a variety of projections of what that population would be should the legislature and the state decide to expand Medicaid, and what those demographic characteristics are. So again, I know it's a frustrating answer, very general answer to your question, but you're right, there are coverage gaps, whether you're looking at Medicare or other public programs where folks don't have as ready access or financial ability to pay for care. And there's a variety of vehicles to address that, but they do come with costs and they do come with strings.
Seeing no hands on my side or in back of me. Proceed, Derek. I think it's time for a hard question for Derek.
Mr. Chairman, I would agree, as hard of a question as you can think of for Garrett. But no, Garrett, thank you for the presentation. Mr. Chairman, that concludes the first overview of our maternal and infant care programs, but we're happy to stand for additional questions or can certainly proceed to the next item.
Any questions to that point, committee? Looks like Dr. Halladon's pushing anybody. Go ahead, sir. It's the middle button. There you go.
Thank you, Mr. Chairman. I have a question on the other public health services. Gap filling financial assistance to mothers and infants who receive care at level 3 out of state hospital. What is that?
Director.
Mr. Chairman, representatives a good example of this is neonatal intensive care units, which we don't have in the state. And so certain folks that go to that level of care, there's gap through Title V, what's called the Title V Maternal and Child Health Block Grant, to pay for certain things when they have to go access that level of care out of state. I can kick it over to Ms. Van Houten if she would like, or if you would like Representative Hallinan to elaborate there. But it's really paying for transportation, paying for hotels, those types of things that the block grant will fund.
Thank you.
Okay, I think we got it. Any further questions, committee? Seeing none, let's move on to the next.
Thank you, Mr. Chairman. We'll move on, getting a little more specific with each of these presentations. The next handful of slides are related to really outcomes, both in terms of pregnancy and in terms of newborn care. You'll see in this presentation as well, a variety of data sources, including Medicaid, what we call our PRAMS data, mental health and substance abuse data that we have from our community programs that deliver mental health and substance abuse services, as well as data from the CDC that gives some population level estimates. I'm going to hand it over, Mr. Chairman, if I may, to Franz Fuchs to go through this presentation. But again, we do have Dr. Harris and Angie Van Houten from our Public Health Division available remotely to answer any detailed questions that you might have. So Franz,
go ahead, sir.
Thank you, Director. Thank you, Mr. Chairman, Madam Co-Chair, members of the committee. Again, Franz Fuchs, Policy Analyst, Department of Health. This presentation is structured, so we're going to kind of start from sort of a very broad overview of looking at all births and trying to, like all mothers, and then kind of narrow down as we kind of progress through it to kind of focus on kind of those targeted issues that we thought the committee might be focused on, like the substance use disorder at the very end. So we'll begin with kind of a very general overview, talking about all births. So you can see this table shows there's a little break there with 2008, but shows the births from the birth trend of all births in Wyoming. So, around 8,000. And that trend has been going down. So the most recent data we have is 2020. You can see there were 6,133 total births in the state. Of that, the next column you can see are the Medicaid births. So I think the interesting trend here is the percentage. And if you look at, 2008, Medicaid was covering around 40% of all births. That trend has decreased steadily over time to the point we're now covering about 30%, 32% to be precise.
Just a quick question for you. Do we know do we know a reason behind that decrease from 42% to 32%? What made us drop 10%?
Mr. Chairman, my speculation would be, so at the 2008, was kind of the peak of the, or the beginning of that, the Great Recession, the housing bubble and everything else. So I think there are a lot of economic factors. Pregnant women eligibility has not changed. The standard has not changed. So really it's the socioeconomic factors in society, how much poverty is there, how many people would fall below that cutoff. I think that's the primary reason why we sort of had a high point probably around that time period, and it's been going down since due to the economy's obviously been better since. Infant outcome, our infant mortality rate and our preterm rate are fairly consistent with the national average at around 5.4 births, 5.4 deaths for every 1,000 live births. And preterm, again, we have about 650 preterm births every year. And that's, again, about average for the United States. We're 23rd.
Another quick question. You may or may not know the answer to this. Where does that compare worldwide? Does the US, I mean, we're average with the US. How does that compare across the world or anywhere else?
Mr. Chairman, we can probably get back to you with more precise statistics, but I think we obviously are, it's pretty good for worldwide, but not as good when you look at just developed OECD type countries. I think it's on the lower end of that spectrum.
I thought Garrett might have the answer.
Yeah.
Go ahead and proceed.
Mr. Chairman, another high level slide here with socioeconomic characteristics. So we have a bunch of text up there talking about the source of this data. This comes from our pregnancy risk assessment monitoring system. This was the 2019 data. And this is really just to give you kind of a flavor of, you know, we have more precise data if you kind of extend the PRAMS timeframe to include more years, and we have more current data if you look, I think the 2020 report's coming out soon, but this just gives you a flavor. Those statistics probably wouldn't change too much. You can see roughly speaking, you know, about a third of mothers would fall under the poverty level. And then around 10% lack a high school education. And then 10% would also report, you know, some indicator of food insecurity. So these are just some rough socioeconomic characteristics of all the in the state. As far as insurance status, I think the most interesting statistic here is looking at the Medicaid. Obviously, we have before, so that we have three kind of segments of these bar graphs. Right, before they're in a prenatal period, we have during their perinatal period when they give birth, and then we have after. So there's kind of three statuses for those mothers as they move through that pregnancy. And you can see the Medicaid coverage increases significantly during, obviously, once mothers become pregnant, a lot of that makes them categorically eligible for Medicaid as long as they meet that income standard. So the insurance rate for Medicaid increases significantly, and the uninsured rate decreases significantly during pregnancy. But then, of course, Medicaid does have that 60-day limit. So the after or postpartum, the uninsurance rate kind of returns to its baseline. And then Medicaid coverage is a little bit elevated because some mothers to that family adult transition to other Medicaid programs. But there is a loss of and then
Chair, quick question.
Go ahead, Representative.
Yeah, Garrett, so looking at these percentages, are we looking at the 2019 data? So we're not looking at pandemic?
Mr. Chairman, Representative Connolly, I'd have to ask the public health folks where exactly this data comes from. I think it is, my guess is that it could be as recent as 2020, but they may have used consolidated 2016 to 2020 data, and which means that the effects would be kind of blended throughout that survey, but I defer to Dr. Harris on that question.
I see Dr. Harris. Go ahead, Dr. Harris.
Mr. Chairman, Representative Connolly, yeah, Franz is correct. This is compiled data between 2016 and 2020, so does include some of the pandemic impacts.
Mr. Chair and Dr. Harris, then I'm curious about the decrease from the 29.6 to the 17.2. So what are we looking at there? Are we looking at postpartum women that have been cut off at 60 days, or they have at least a year of eligibility, or is it mixed because of the number of years that we're looking at?
Dr. Harris.
Mr. Chairman, Representative Connolly, it would be mixed. So for 2016 through 2019, you know, it would represent some of that 60-day cutoff period. And then for, you know, most of 2020, it represents that women would stay on after that 60-day period. So it is mixed.
Again, one just follow up. So then I'm looking back at the 12% before. If we weren't including the extension, would it be more likely that we would see a lower number than this 17.2% back down to the 12%?
Dr. Harris.
Mr. Chairman, Representative Connolly, just to make sure I understand the question. So you're saying that if we were potentially to extend that coverage like we have in the pandemic, would we potentially see that 17% grow higher and more women would stay on Medicaid afterwards?
Mr. Chair, just the opposite, that we would see less. If we cut it, if we did not keep the extension, we would see a drop in the number of women who have insurance.
Mr. Chairman, Representative Connolly, yes, I do believe that's likely.
And Mr. Chairman, Representative Connolly, I would just add that I think it probably wouldn't drop down to the 12%. I think there's a number of women that do transition to other Medicaid programs, even pre-pandemic. So like going to the family care adult program. And we have some slides on that kind of showing the length of time on Medicaid overall. And there is a segment of mothers that do transition to longer, to other programs and thus stay on Medicaid for longer.
Okay, go ahead and proceed, John.
Moving on to some clinical characteristics. So just looking at the care that was received by mothers throughout their pregnancy. You can see that the vast majority of mothers, I guess 87% is a high fraction of mothers receive prenatal care beginning in their first trimester, which is good. Obviously that should be higher, but it's heartening to see that number. We do have I'm not sure. I think our C-section rate is a little higher than the national average. I'd have to defer to the health officer folks, health officer and other public health folks. But generally speaking, these PRAMS data are relatively consistent with national averages, particularly when you consider the confidence interval, right? So this is survey data. They're serving a subset of mothers, so we're extrapolating that data to the entire population. And so that comes with uncertainty, which you can see those percentages are not exact. But Dr. Harris or Angie, any highlights on here that, do we differ from the national average significantly in your perspective?
Go ahead, Dr. Harris.
Mr. Chairman, I'm just waiting on an answer about C-section deliveries. We do tend to be a little bit higher in that category, but in some of these categories, we actually are slightly better than the US average. We don't have that one on here, but for example, a postnatal visit, we tend to be a little bit higher than the US average, which is good, but relatively comparable.
Okay, Franz.
Mr. Chairman, continuing on to health measures. So these are general health measures for considering things like obesity, hypertension, diabetes, and depression. And we measure depression both pre-pregnancy on the survey and postpartum. So you can see the incidence there. Moving on to tobacco and alcohol use. I think the tobacco use during the last 3 months of we're a little elevated, that 11.4%, we're a little bit elevated from the national average. One of the most significant differences there, but otherwise we are, I think, national averages.
Just an interesting fact, there's just a nuance. Do we look at vaping versus smoking? Or is there maybe something we don't know? Go ahead.
Mr. Chairman, I'd have to defer to Dr. Harrison. I don't believe PRAMS does. Maybe the most recent update does, but I'm not sure it does. But Dr. Harris, please, if you wouldn't, if you know.
Mr. Chairman, yes, the PRAMS survey does ask about e-cigarette and vaping use, and that those information should be available on our PRAMS dashboard. I don't have them available for you right now.
Good. I anxiously await. Thank you. Go ahead, Franz.
And Mr. Chairman, kind of wrapping up this section of the presentation, talking about harder substance use, not just alcohol, tobacco, but looking at outside of alcohol and tobacco. We sort of try to triangulate this based on Medicaid and data from our mental health block grant data reporting system, which covers anyone who's seeking services and being diagnosed. So it's not necessarily an exact number of people that are using, it's people that seek treatment. Income pregnant women that do treatment not related to alcohol, drug issues are about a third meth, a third marijuana, and about 12% opioids. That's kind of the primary drug. That's the issue.
Go ahead, Chairman.
Thank you, Franz. So this brings an issue, which is one of the things that led me at least to put this topic on the interim. We had that discussion during session about, the potential criminal charges against mothers that were using one of these drug during pregnancy. And one of the questions that came up was on the data. Estimated 50 to 75. And it's possible that you will get into this a little bit later in today, and if that's fine then. But I'm curious, and Mr. Boley or somebody may later have information, but what would be our process for enabling whoever is doing the delivery, physician or nurse practitioner or midwife, for recording in some way a newborn that from there, and I don't even know what the clinical measurement would be. We probably need to hear from clinicians, but I guess, is there a way that we can get better data than an estimate so that we can follow up on the babies and the mothers? Any thoughts on that? Is that something that will come up later, or is this the line item
Go ahead.
Madam Chairman, so when I say estimate here, this is basically when we look over time, it's kind of the number fluctuates. It's not a, consistent number every single year. So this is kind of a range. Every year we see between 50 to 75. It comes from, this data source is Medicaid. So it's administrative claims data and it's diagnosis codes that are recorded for neonatal abstinence syndrome. So there's a variety of ICD-10 codes that correspond to various types of NAS by substance. And so it is administrative claims data. It really depends on, I think the quality of the data really depends on how clinicians are recording those diagnoses. And I can't unfortunately speak to that, how that happens in the hospital. I'd certainly defer to anyone in this room on how that process happens, rigorously, or how thoroughly every mother is assessed or every neonate is assessed on those diagnoses.
But so this is only then Medicaid newborns. I mean, I don't know that we could necessarily assume that a mother who has either had private insurance or was uninsured, I mean, would they be more or less likely to be using some, I mean, I guess, so that if Medicaid births are whatever it was, a third, we could be conceivably we could be conceivably having 150 to 200 newborns in the year. I mean, if it were the same across. So I guess all of you out in the audience, this is something I really want us to be able to pin down so that we can make sure that these babies are getting the help that they need. I mean, I think, yeah, I'll leave that float out there.
Go ahead, Franz.
Mr. Chairman, Madam Co-Chair, my guess would be, just educated guess, is that 50 to 75 would be the bulk or most of those newborns. I just simply because substance use likely correlates with socioeconomic and social determinants of health. And that would also correlate with Medicaid eligibility. So just being poor, right? I don't want to cast any judgment or try to have any gross biases here, but my educated guess would be that would be probably the bulk. However, I don't think there is a systemic claims data system that would be able to record all NAS diagnoses, for privately insured mothers, for example.
Okay, proceed, Franz.
The next part of this presentation, Mr. Chairman, and cooperation between public health and Medicaid, as well as the state of Utah. And the goal of this committee is really to review on a case-by-case basis, really taking every pregnancy-associated death or any death that has any indication of pregnancy within a year for Wyoming residents, and to review those cases with the aim of trying to make policy recommendations to improve services both on a state, but also potentially on a clinical or hospital level. And you can see the key decisions that the committee makes in its review. Really was the death causally related to the pregnancy? Because there's sort of this larger group of pregnancy associated deaths where the death occurred within a year of pregnancy, but then you can subset that to the deaths that were actually caused or related directly to that pregnancy as opposed to incidental. What was that underlying cause of death? Was the death preventable? And what were the factors that really contributed to that death? And then really looking at if that death could have been avoided, what changes, what policy or procedures could have been changed, actions taken either on the clinical, the hospital, or the state level that might have prevented or changed that course of events. So that's really the goal of this committee. Their final report is coming out, I believe, in July. We do have some preliminary data from that. This slide kind of shows how you neck down, you take that total, casting that net, right? All those pregnancy associated deaths, and you're necking it down really to those what are called pregnancy related deaths, which is that causal relationship. And then maternal death is even a subset of that, right? Within 42 days of that pregnancy.
Go ahead, Representative Collins.
Yeah, thanks, Mr. Chair. And Mr. Fuchs, I'm wondering if you could get us some more information. I want to go back to a question of Representative Wilson on substance use and SES status You made a comment that you assumed that there was more use, and I just pulled up some data and I'm not seeing that. And what I did see is that it's more correlated with age as opposed to income level. And so if you could kind of get us more accurate information about that, that would be valuable. Thanks.
Let's see if you got comments first.
Mr. Chairman, Representative Collins certainly can do that. I certainly don't want to comments here. That was just my guess. And we'll try to get back to you.
Okay, I see a couple hands down here. Representative Bobby.
Thank you, Mr. Chairman. Mr. Lukes, on this, it says that they're reviewing all pregnancy-associated deaths or any death with an indication of pregnancy. So would this be coming possibly, is there data in here that goes along with abortions?
Mr. Chairman, Representative Ottman, I do not know. I would have to defer to our public health folks, Dr. Harris or Angie, if you might know the answer to that question.
Mr.
Dr.
Chairman,
Harris.
thank you,
Go
Mr.
ahead.
Chairman. Representative Ottman, we would include in this review any death among a woman who was pregnant within 365 days prior to death or who was pregnant at the time of death. So yes, if she had an abortion and subsequently died, and we had an indication that she was pregnant, that death would be reviewed.
Mr. Chairman,
Okay, go ahead, Representative.
thank you. I'm kind of curious. I want to go back to the issue of cesarean deliveries. I'm looking for data, picture as a whole. Does Medicaid, so I just want to talk about cesareans, and with my particular experience with constituents, we have cesarean deliveries. I'm not sure what was stated, if our percentage is high or normal according to statewide or national averages. I'm unsure, but particularly with cesareans, is a mother able, who's on Medicaid or just anybody, it doesn't matter, uninsured, private, in order to prevent a cesarean, are they able to get an epidural? Is that a service paid for? To try their best to prevent a cesarean and to have a natural birth. And then with my experience with cesareans, with constituents and stories I've heard, what is the data? And I want to go back to substance abuse. So when you have cesareans, very painful, I speaking from experience, longer recuperating time, and then, about that relate to opioids abuse. When you have cesareans, it's painful. My experience is high levels of postpartum, they're suffering mentally, and especially with the pandemic coming on, but I want to look particularly at that data. But is there a statute? I know this is fully loaded, but is there statutes that prevent mothers in this state from utilizing an epidural to help them their pregnancy to successfully have a natural birth?
Go
Mr.
ahead,
Chairman, if I may, Representative LeBeau, just answer generally and certainly have Dr. Harris weigh in if she has more detail. A couple of questions that I heard in there. First, on the Medicaid side, are things like epidurals, et cetera, covered so that we're not, incentivizing one type of birth over the other? In general, in Medicaid, anything that's medically necessary, ordered by a physician or provider within certain limitations is reimbursable. So there's certainly not a prohibition there on an epidural on the Medicaid side if it was medically necessary. I will also mention that pregnancy-related claims are in Wyoming Medicaid reimbursed as a bundle, kind of a global bundle of services, and that can be adjusted, depending on the circumstances. Your other question, do we see any correlation relation between, C-sections and certain types of substance use. I think you mentioned opioids. I don't know off the top of my head. I think we'd really have to dig in and look at that. I would caution the committee, when we go chasing some of these, correlations with numbers being so low, we try to be careful, saying, well, in this certain year, we saw this number of cesareans, and this survey reported number of individuals, pregnant women that reported substance use. We'd be very careful not to chase noise there, but we can certainly look into that and see if there's anything, confounding there that would be worth reporting. Dr. Harris, I know there were a few other questions in there. Feel free to add any color commentary that you might have.
Dr. Harris, go ahead.
Thank you, Mr. Chairman. Representative LeBeau. Yeah, I agree that I really think that the decision whether to give an epidural is one between a patient and a provider, and that there's nothing that would limit that procedure if indicated and if the patient chose to do that. There are a lot of medical reasons why vaginal deliveries have helped benefits relative to C-section for both the mother and the baby. But I, like Stefan, am unaware at this time. I don't think we have any data or whether there's any national data on whether a C-section might predispose somebody to opioid misuse.
And I have a feeling, Representative, that you mentioned opioids in there for post C-section, an example. I have that other measures, surgeries, et cetera, and the opioid use. For instance, there are statistics on, the length of time for which an opioid is given relates to the possibility or the chances of addiction. And I have a feeling that those are lumped in with all the medical procedures, and to tease those out would be a difficult thing to do, number one. But I have a feeling that data lies within the data for all opioids and all medical procedures.
I get looking after certain things, but from what I see and what I hear, I represent the Wind River Indian Reservation. Personal experience. I've had four children. My oldest children, I had to have an emergency C-sec. Suffered with postpartum, got me strong narcotics to deal with the pain. I have two daughters, two sons, two daughters, but both daughters, we take a long time to dilate. So I was able to have an epidural, but now they're telling my daughters, you can't do an epidural, obviously, because it must be under their discretion to say it's not medically necessary. Once you have a cesarean, you're going to have a cesarean for all the rest of your babies. And I have my oldest daughter suffering with opioid now. Personally, and we were talking about the babies, but we also got to talk about the mothers too. They need that care. And I can tell you that my other youngest daughter was told by the doctor she can't have an epidural. Obviously, the excuse wasn't, it's not medically necessary. They just said, we're not going to give you an epidural so you could have a vaginal delivery. We went out that baby. So the first son, she had to have emergency section, just like me. But I could tell you, the well-being, the mother, the bond, the limit of the postpartum, it's huge. It's so huge and crucial. So the mother's there healthy, able to take care of the baby. She doesn't have to get those opioids prescribed to her. Huge difference night and day. So that's why I say that. Thank you.
Mr. Chairman, if I may, Representative LeBeau, if I was unclear, I'll clarify now. Certainly not indicating that any of that lived experience we see is challenge to prove that with comprehensive data sources. I think there's where the limitation is, but certainly didn't mean to indicate that those lived experiences were not there.
Oh, there's a hand online. Senator Hutchings, go ahead, ma'am.
Thank you, Mr. Chairman. This question possibly for Franz. Back to the prenatal care beginning in the first trimester. Estimates about 87%, pretty high. I'm wondering why, and I don't know what goes on in prenatal care, but I'm assuming there's a blood test. Why, if it isn't already happening, you cannot, or it cannot be determined whether the mother is abusing substances. Just wonder if that's something that could be caught early.
Franz, go ahead.
Mr. Chairman, Senator Hutchings, I honestly don't know the answer to that question. I'd certainly defer to Dr. Harris as a clinician, but I'm not sure that kind of system or procedures exists. So I would certainly defer to our public health folks.
Dr. Harris?
Thank you, Mr. Chairman and Senator Hutchings. Yeah, the American College of Obstetricians and Gynecologists, the physicians who primarily take care of pregnant women and deliver babies, do recommend doing verbal screening about substance use, along with all of sort of the other questions and guidance that is given at these prenatal visits, with the hope that then, the provider can identify an issue and get that woman the support that she may need.
Okay, Franz, proceed. Oh. Nope. Go ahead, Franz.
So, Mr. Chairman, just continuing with the maternity mortality review committee slides, talking about sort of the initial findings this is reviews 3 years of data, 2018, 2019, 2020. And you can see that the committee reviewed 13 pregnancy associated deaths, that's that larger circle, and then necked it down to 6 of those 12 deaths. So one review was not possible due to the need to work through the legal process there, but they reviewed 12. Of those 12, 6 were classified as pregnancy related. So 5 were not, and 1 could not be determined. And there was a sort of a significant behavioral health kind of component to a lot of these deaths. Mental health conditions were the underlying cause of deaths in 4 of 6, and substance use was involved in all 6.
Chairman Wilson.
Thank you, Mr. Chairman. So Franz, this question has been percolating here. So my understanding is that one of the highest causes of maternal death is domestic violence. And so I'm kind of surprised that, frankly, that with that in there, the numbers aren't higher. So I'm wondering, is that from the this committee, is that considered a pregnancy related death, or do you know what they do with a domestic violence situation?
Mr. Chairman, Madam Co-Chair, I know one of the unrelated deaths was classified as a homicide. I'm sure they review those deaths and really try to evaluate whether the pregnancy was causal, as far as domestic violence goes. But I think that one, so yes, I think the answer is they do review those on a case-by-case basis, and that would be included if that wasn't a major cause. As far as the numbers themselves, I would just caution the committee, these are obviously a very small number, just generally, and when you're dealing with small numbers, it's just very difficult generally to extrapolate what is the true, population level cause, right, on a national scale. I think if you look at national data, for example, a lot of the pregnancy-related deaths are due to cardiovascular type factors. And so it's a little different, not saying that's a big cause in Wyoming, but of the deaths that were reviewed, it really, it's again, a small number, right? 6. And it just happened to be that it was really sort of this mental health conditions that were causal for 4 of those 6, and substance use was involved in all of them. So just it may be a little bit different than what the national narrative is around this issue, but I just have to caution the committee that the small number is just hard to make conclusions around.
Okay, Representative Cohn.
Yeah, thank you, Mr. Chairman. Admittedly, I understand what you're saying with 6, but when I read this last week, I remember sitting back and thinking, oh my God, we lost 6 new moms in this state, 6 new moms. And what can we do about it? To me, that was a lot. 10 to 1, we have 1 or 2 degrees of separation from each other, that if I dug just a little bit, I'd know who that was. So it really, really impacted me when I read this. And I needed, to get up and walk around. So I was thinking when I was reading it, do you have any data about whether or not these new moms were getting any care for those conditions, for their mental health conditions, for their substance abuse?
Go ahead, Franz.
Mr. Chairman, Representative Connolly, we do have a couple findings on insurance status. The report itself is coming out in July. I think there'll be more detail there. I would certainly like to give Dr. Harris and the public health folks more time to comment on this particular, this is their baby. This committee has their work. And just because we're here in person talking about these slides, they're the experts, and I'd like to give them some time to talk about that, and maybe they might have some more information they could share. But I know that the final report is coming out in July.
Dr. Harris, Randy, anything you'd like to share at that point?
Thank you, Mr. Chairman and Representative Connolly. And if I may just, comment on your point that we totally agree. Six is too many, 1 is too many. Anything more than 0 is too many. I think though we do have to be, I think Franz's point was that with numbers like this, we do have to be cautious making, big generalizations, but anything over 0 is too many. The committee did look at what they considered to be contributing factors among these deaths, and the factor involved involved the most was a lack of access to healthcare, or a lack of financial resources to access the appropriate care. So yes, absolutely, that was identified as a major factor in these deaths.
Okay, Representative Stivar has a question.
Thank you, Mr. Chairman. With this data, was it correlated with any of the 12 states that actually have drug testing for benefits, and how their stats are matching up to the states that don't have the drug testing requirement?
Mr. Chairman, Representative Stivar, my understanding of this whole process, the MMRC, is that it's in its early stages, and it's very piecemeal across states. So there is no real comprehensive data set across all states that you might be able to use to kind of draw those conclusions or try to estimate correlations. But I'd certainly defer to Dr. Harris on that question.
Dr. Harris.
Mr. Chairman, Representative Stivar, no, as Franz said, this is our first report. Again, it's very hard to calculate rates that we, think are epidemiologically reliable, and make comparisons over this short a time period. And so we have not made those comparisons at this time.
Follow
Follow-up, Representative Stivar.
up? Because you mentioned you're working with the state of Utah. And Utah is on this list that is requiring drug tests. So that's why I was wondering.
Franz.
Mr. Chairman, my understanding of working with the state of Utah, I think it has something to do with the grant they received and sort of the financing of this committee. I don't know if there's other specific reasons why we are working with Utah, but I'd again defer to Dr. Harris on why we're working with Utah specifically.
Dr. Harris.
Mr. Chairman and Representative Stivar, yeah, we're fortunate to be able to partner with Utah. Obviously, Utah is in our region. They are a state that's next door. They do have, some types of specialty providers that can sit on the committee that we don't necessarily have, because we're combining both, and discussing both Utah and Wyoming deaths. We can have meetings more frequently, rather than the number of Wyoming deaths would probably mean we'd have fewer meetings. So it really gave us the opportunity to join into an established MMRC, gain that experience. We certainly do hope as CDC expands this funding and makes it available to all 50 states that we would eventually run our own MMRC.
Okay, Representative Ottman.
Thank you, Mr. Chairman. This would be just a clarification from Ms. Harris, please. What I read here was that substance use was a very strong factor in this. In fact, of the 6 that were deemed pregnancy related, substance abuse was all of them. I thought I heard you say that the main thing was low income. That doesn't, I don't see that here. Could you help me out? Thank you.
Dr. Harris.
Thank you, Mr. Chairman and Representative Ottman. And I can clarify what I had said is that the committee identified factors that contributed to these pregnancy-related deaths. And the factor that was identified the most, 21% of the time, was lack of access or financial resources. So a combination of potential financial issues with accessing resources, but also potentially, resources weren't available in the community for the woman to access.
Representative Worf.
Thank you, Mr. Chairman. I guess I've got a lot of questions, but my first question is, who is on this review committee?
Mr. Chairman, Dr. Harris, would you field that one, please?
Sure. Thank you, Mr. Chairman. So on this committee is a variety of providers. So we have perinatal and reproductive physicians, psychiatrists. We have representatives from Wyoming Medicaid, public health nursing, a family medicine specialist from Wyoming, an OBGYN, an epidemiologist, and a women and infant health program manager from the Maternal and Child Health Program. So really a mix of providers, specialty providers, mental health providers, and then primary care and public health providers in Wyoming.
Follow up, Representative Worf.
Yeah, follow up. Thank you, Mr. Chairman. I guess when I look at this, when we're trying to determine cause of death, how do you avoid this leading to litigation? Because obviously you're going to find something. That's the purpose of it, is to identify that cause of death. And I guess the question I have, first of all, is, how are you avoiding litigation once you determine somebody was at fault? That's the first question.
Technically, that would be your second question.
No, that's the first after we know who's on it.
Mr. Chairman, Representative Worf, I'm going to once again defer to Dr. Harris, but I will say that with these types of committees, again, kind of in its infancy here in Wyoming with our partnership in Utah, I think liability and immunity issues are a big topic of conversation, both for the folks who sit on the committee, as well as, what the implications might be beyond that in identifying causes. But I know it's a very hot topic of discussion when you do these. Again, from my perspective, one of the benefits, and as Dr. Harris mentioned, we're fortunate to be a part of this grant and have some financing and partner with the state of Utah, is to really look, academically and epidemiologically at causes, not necessarily at punitive measures for what might have occurred in a specific setting. There's other vehicles for that, but this is really more, I think, on the medical, clinical, and epidemiological side. But Dr. Harris, I know it's been a huge topic of conversation, so please correct anything I misstated or add any detail.
Go ahead, Dr. Harris.
Thank you, Mr. Chairman and Representative Worf. And I agree, immunity and liability issues, are there, but really the goal of this committee is not to assign blame. That's not what the committee members are looking to do. They're really looking to identify, sort of systematic factors at various levels that we could improve, or that, additional training or additional resources could be implemented to then help prevent these deaths occurring in the future. So we're not trying to find an individual or something, or a provider or a hospital to blame. It's really trying to identify these systematic factors where, evidence-based practices, additional trainings, additional resources could be implemented to prevent these deaths in the future.
Okay, further follow-up, Representative Worf.
Follow up, Mr. Chairman. I appreciate that. I guess that's one of the things. I understand this is a new program, but I guess that's one of my biggest concerns is I know just the expense that's tied up in medical practices. And I know, I don't need to tell you guys, but litigation is a huge factor in some of our medical cost. And so I guess that's one of my concerns. When you're determining cause of death, I don't know how you can't be determining blame, because you're saying what caused that death. And I guess I have some concerns. the reason I ask is because I'm wanting to make sure that we're getting the right data, because I think that is the intent so that we can solve the problem. But I do worry that we're not exposed a little bit. I guess that's one thing I'm asking is if it is, after going through this, if it's determined that we're not able to get maybe 100% accuracy on the data for fear of prosecution or litigation, I guess that's one thing I would be interested in, is if there's a recommendation, something we need to do to fix this problem so that we can actually try to drive it to where, you know, we minimize the losses that we can. So that's just a comment, but I would be interested in working with you if there is a need. But the last thing, Mr. Chairman, when you talked about mental health conditions being a factor, it brought to light a problem that I just recently became aware of, and that is some of the problems that we're having at the state hospital. Were any of these patients in any way linked with our state hospital? If you can say that, I don't know if you can.
Mr. Chairman, Representative Worf, I don't believe so. You know, having overseen the state hospital for several years myself, I don't believe any patients there were included in these numbers. And I wouldn't want to confirm or disconfirm that here publicly, given the privacy implications there.
Yeah, and the only reason I bring that up, Mr. Chairman, is I was alarmed when I was told of some of the problems that are going on at our state hospital. So you and I probably need to have a private conversation, because when I saw that, that was a huge flag to me. So we can visit on a sidebar, but I do want to talk to you about it.
Mr. Chairman, Representative Worf, happy to do that at your convenience.
Thank you.
Okay. Further questions, committee, before we move on? Seeing none. Go ahead. Ron.
So, Mr. Chairman, the last slide here just kind of relates a little bit to that access issue, but we do know in the case of 3 mothers that they did lose insurance coverage before the time of death. In 3 of those 6, there were Medicaid moms, and 2 had lost eligibility postpartum, and then one of the deaths, the mother had lost private insurance coverage. So just a brief indicator there. Again, maybe certainly not causal per se, but certainly potentially contributing to that access concern.
Okay, I believe I saw Senator Hutchings' hand up there. Go ahead, ma'am.
Thank you, Mr. Chairman. You did see my hand up, but the speaker did mention that this wasn't causal. I do believe I heard earlier on the mental health section, I don't know if it was Franz or Mr. Johansson said, substance abuse was involved in all of these cases where the mental health conditions, the underlying cause of the death in 4 of 6. So I'm glad he did state that there's no correlation. You lose your Medicaid, so you die. So thank you.
Comments, Senator?
Mr. Chairman, I would just, say that I think that when they evaluate these deaths, there's a, if you think about it like kind of like a fire, there's an immediate cause of that fire, which is the spark, but then there's also contributing conditions, right? And so I think access to coverage would be like the tinder or the dryness, in that fire compared to the, maybe not causally causing that, but maybe contributing to the underlying. So I think there's just a layering of causes potentially that to be considered. And so that'd be my comment on that.
Very good. Further questions or comments, gentlemen? Seeing none, we appreciate it, and we'll let those seats not get cool. We have other people that want to jump in there, I believe. Thank you, Garrett. That was very good. You got off the hook. Nobody hammered you too hard. But, oh, there was a question in there. Oh, I'm sorry. Dr. Hallinan.
Thank you, Mr. Chairman. What is the evidence that the loss of coverage had anything to do with the deaths of these 3 individuals?
Mr. Chairman, Representative Hallinan, I think the idea is that this committee assessed that access to care was a contributing factor. And so insurance is obviously one of those factors that provides access, right? Financial access to pay for care. Now, there's other aspects of that. There's physical access. Is there a provider or clinic in that community? Does it exist at all? That also could have contributed. I can't speak to these particulars on these deaths. I think the report is at a relatively anonymized level. And so as far as each individual specific case, I don't know if Dr. Harris has any more to add, but I think the idea really is that the committee did assess, access being a contributing factor, and health insurance is one component of access.
Dr. Allen.
Thank you, Mr. Chairman. Is the report of this committee available to us to look at?
Mr. Chairman, Dr. Hallen, and it will be released next month. These are just interim results.
Very good. Dr. Harris, did you have any comments on that? No.
Oh, no, thank you, Mr. Chairman.
Okay, very good. Gentlemen, being the chairman, it's my prerogative of order. We bring these people down here, and I know people that are on the schedule wanting to discuss some things with us. We're going to start off with Ms. Shippen, if you would, please. Welcome, Donna. It's good to see your smiling face this morning.
Thank you. Good morning, Chairman Baldwin. Good morning, committee members. I'm going to share my screen. I prepared a little PowerPoint. All right. This PowerPoint summarizes the research memo that is behind tab 3 in your binders. And the subject of the memo is infant prenatal substance exposure. As you know, this is a subtopic of the committee's interim topic concerning maternal and infant care. I prepared this memo for the committee in an attempt to provide an overview of the issue. In the memo, I summarize what federal requirements are for states regarding identification of infants with prenatal substance exposure and providing services to those infants and mothers. What Wyoming efforts are to date to meet those federal requirements. I looked for Wyoming data regarding infants with prenatal substance exposure and also what state-funded services are available to pregnant and postpartum women with substance use disorder. And if I can get my see if I can, whoops.
All right, let's get, Senator Hutchins has a question real quick while you're getting that up. Go ahead, Senator Hutchins.
Mr. Chairman, I didn't get the name of the presenter.
Oh, I apologize. I'm Donna Shippen. I'm with LSO.
Thank you. Hard to kind of see you. Thank you.
Okay.
Thank you, Senator.
Now I know who you are. Yeah.
So what are federal requirements regarding infants with prenatal substance exposure? The key federal legislation addressing child abuse and neglect is the 1974 Capta Act. It provides guidance and grants to states regarding the identification and assessment, investigation, treatment of child abuse and neglect. The Capta Act was amended in 2016 by passage of what's called the CARA Act, the Comprehensive Addiction and Recovery Act. CARA Act established some requirements for states that receive Capta funding. States are to have policies and procedures in place regarding identification of infants affected by prenatal drug or alcohol exposure. They're supposed to have requirements that healthcare providers notify the state child protective service system of these infants. States are also required to have a system in place for the development of post-hospital discharge plans of safe care for the infant and mother or caregiver, and a state system for monitoring referrals to services and service delivery. The CARE Act specifies that notification of an infant with prenatal substance exposure is not to be construed as a report of child abuse or neglect. And the Wyoming Department of Family Services provided these definitions to me of a report versus a notification. So a report to the Child Protective Services occurs when there are safety concerns for the infant. When DFS receives a report, they assess the report and the child's safety. Based on that assessment, DFS may initiate an investigation of child abuse or neglect. Notification occurs when a newborn has been exposed to substances prenatally, but there are no other child protection concerns. In that case, the family would be referred to an outside provider, such as public health nursing or parents as teachers, not to the DFS Child Protective Services system. And that outside provider would provide a plan of safe care for that infant. Currently, the state lacks a process for notifying DFS of infants exposed to substances other than to make a Child Protective Services report. But the Department of Family Services has been working with the Department of Health and the National Center for Substance Use and Child Welfare Technical Assistance Program to build a statewide notification system and procedures for healthcare providers to follow when they identify one of these infants. I looked for data concerning the number of infants in the state with prenatal substance exposure. There's not a lot of data out there. I did reach out to both DFS and to the Wyoming Hospital Association, and they were able to provide me with some data. This is data that DFS provided regarding CPS reports of infants with substance exposure in 2021. There were 173 reports made to DFS. Those reports concerned 142 infants within 140 families. Based on those reports, DFS opened 113 child protective cases and 37 infants, as a result, 37 infants were taken into protective custody.
Question, Representative
Yeah.
Conley.
Ms. Shippen, often infancy means from birth up to a year old. So I'm curious if your data, when you talk about infants here, are you talking about that span or are you talking just at birth?
I am going to defer to the Department of Family Services to answer that. If I could, please.
Come on down.
Actually, Mr. Chairman, there is Lindsay Schilling is on the line.
Okay. Come on down. That way, everybody, yeah, come on down. That's what you get for sitting on the third row this morning. Welcome to Labor and Health. Go ahead and introduce yourself and fill us in.
Mr. Chairman, members of the committee, my name is Corin Schmidt, and I'm the Director of the Department of Family Services. To your specific question, Representative Connolly, that's birth to 1 year.
Follow up. Go ahead.
Yeah, thank you, Mr. Chair. So it is interesting to me that we're going to use up to that full year, but we do really want to be thinking about what happens. The questions that we were receiving were about what happens at birth when a mom or a child tests positive. But now, so now I am a bit confused. When you have substance of concern, are we talking about at birth or are we talking about that full year? And when and how did that notification to DFS take place? And then ultimately, I want a question about kids taken into protective services. When are they returned? All of that. So I am kind of curious about all of these numbers as they relate to thinking right at birth, which to me is one question, and then later on.
Go ahead.
Mr. Chairman, Representative Connolly, the notifications typically happen at birth. And so I think you could assume that the infants taken into protective custody at this time were at birth. But we can certainly drill through some of the data to find that. I do want to add the caveat, however, that this data is manually collected. We do not have a system by which we can go through and just query the system. So the reason why this data is pretty limited and it's only 1 year is because we did do a manual review of all the cases we had in our system that had flagged somehow. So this information is not complete, but it does give us some sense of what we're dealing with right now.
Okay, thank you very much, Director. You can just stay here. You don't want to go back there anyway. Go ahead and proceed, Ms. Shippen.
All right. This slide shows data that the Wyoming Hospital Association provided me with. They report hospital discharge data regarding newborns who are diagnosed as affected by maternal use of alcohol or drugs, or infants with neonatal withdrawal symptoms. It may be hard to see this chart on the slide. I don't know, it's on page 6 of the research memo. You'll see based on, so this is data from 2016 through 2021, broken out by county. State totals, there were 32 infants diagnosed with substance exposure in 2016, a high of 106 infants in 2019, dropped back down about 67 in 2021. When you look at the county data, on this slide, I don't show any numbers less than 10. So if you see an asterisk, that means it's a number less than 10. But looking at the counties which reported the greatest number of infants with substance exposure, it's 4 counties: Campbell, Fremont, Laramie, and Natrona.
I hear a voice. Representative Ottman, go ahead.
Thank you, Mr. Chairman. I was just wondering on page 5, Donna, could you tell me what anticonvulsants are?
Oh, okay.
Thank you. It's at the very bottom.
Go ahead, Ms. Shippen.
Yeah, I'm sorry. Let me get to my research memo. Anticonvulsants.
Convolutions, convulsions, yeah.
And again, I would defer to someone in the audience, maybe with more medical expertise than I have, to answer that question. Perhaps Chairman Baldwin.
Quit looking at me when you say that. Anticonvulsants mean things that prevent seizures.
Thank you, Mr. Chairman. I just wondered because the other things we were looking at were THC and different things and alcohol and opiates. So I wondered, so thank you.
Okay, go ahead, Ms. Shippen.
All right. So as part of this research memo, I also looked at Medicaid data regarding pregnant women. And some of this is going to be a repeat of what you just heard from the Department of Health. But Wyoming Medicaid does fund about 33%, an average of 33% of births statewide, so approximately 2,000 births per year. However, the percentage of Medicaid births does vary by county. So the counties with the highest percentage of Medicaid births in 2020 were Fremont with 49%. The other 6 are listed there. And then I highlighted 3 of these counties were also counties, according to that hospital discharge data, that reported the highest numbers of substance exposed infants. Again, this slide just repeats the data that the Wyoming Department of Health already shared with you regarding the incidence of Medicaid pregnant women who have behavioral health or substance use disorder treatment, who sought treatment for substance use disorder, and the number of newborns who were diagnosed with substance use exposure or alcohol exposure. So what substance use disorder treatment services does Wyoming Medicaid provide to pregnant and postpartum women? Pregnant women are provided full health benefits while they are covered by Wyoming Medicaid. And these include limited substance use disorder treatment services. So those full health benefits are available to women for up to 60 days postpartum. And as the Department of Health indicated in their presentation, at the end of the 60-day postpartum period, approximately 70% of Wyoming Medicaid eligible pregnant women are disenrolled because they do not meet eligibility criteria. This would be pre-public health emergency data. Currently, no women are being disenrolled from Medicaid.
Representative Wilson.
Thank you, Mr. Chairman. So I have a clinical question, Donna, so you're going to have to divert the question as a lifeline, but I want to ask it here just because it fits in. I've been underlining the number of newborns diagnosed with some form of substance use withdrawal and the newborns, and then 5 to 8% of Medicaid pregnant women seek treatment for illicit substance abuse issues, and then I'm not seeing if there was an alcohol or if you, but my question is, and here's the clinical question from somebody, I know recovery can be a lifetime issue, but how long might we suspect that a person who seeks treatment for substance abuse issues would need to receive some kind of care? And again, as I say, I understand out of the audience that recovery is for life, but if they start receiving substance abuse treatment, say in their 4th month, and then they've got 5 months left of their pregnancy and then 2 more months. I was going to take the answer to that question and apply it for our later discussion about expanding the Medicaid coverage. But do you have a clinical person that you can direct my question to?
I would defer that question, I believe, to WAMSAC.
Be the next person that's presenting.
Okay, we'll just put that on pause there until
Just start.
this summer, right. So committee, that if you'll just think of what, as you see on the agenda, Mr. Chairman, we have before us a question of whether we might continue the postpartum coverage for a full year. And my thinking is, if we've got, let's say 10% of the pregnant women seeking treatment for substance abuse and they're cut off after 60 days, we might really be able to do something beneficial if we extend it and obviously then pass them off into other recovery providers later. But so that's why I'm asking that. I'm sorry, Donna, go ahead.
Good segue. Okay, go ahead, Ms. Ship.
Okay. And maybe this will answer your question partially, Chairman Wilson. So the American Society of Addiction Medicine classifies substance use disorder services into 9 levels of care that are grouped into 5 broad levels of service. So there are prevention and early intervention services, outpatient services, intensive outpatient or partial hospitalization services, residential services, and intensive inpatient services. Wyoming Medicaid covers 3 of these 9 levels of care. I've highlighted those. They cover early intervention, outpatient, or intensive outpatient services. Wyoming Medicaid does not cover residential or inpatient substance use disorder services. Wyoming is one of 7 states whose state Medicaid plan covers 3 or fewer levels of care. A majority of states cover 6 or more levels of care. And this map shows that coverage, state Medicaid plans and what they cover, how many levels of care they cover. Because of that gap in Medicaid funded substance use disorder services, the Wyoming Department of Health instead provides block grants to community mental health and substance abuse treatment providers to fund residential treatment beds. In 2022, the Department of Health provided grants to 4 providers around the state to fund a total of 256 beds. However, less than 10% of these beds, just 21 beds, are available to parenting women. Parenting women are defined as pregnant women or women with small children. And the location of these parenting women beds does not necessarily align with the counties that report the highest number of infants with prenatal substance exposure. So if you recall from the Wyoming Hospital Association data, the discharge data, the 4 counties with the highest incidence are Campbell, Fremont, Laramie, and Natrona. Natrona County does have 4 parenting women beds. The other 3 counties, there are no parenting women beds in the other 3 counties.
Go ahead, Representative.
Thank you, Mr. Chairman. And Donna, just to touch on that, in your research, did you note any private partnerships in those counties that have more available bed space? Any information there?
There are private providers, more private providers in the state that don't receive state funding. But in order, my understanding is to access those private services, you would need private insurance or self-pay.
Okay, thank you.
And I, stand to be corrected by WAMSAC or anyone else.
Just keep building those questions up for WAMSAC. They're coming up next. Go ahead.
And then the last couple pages of the research memo summarize a federal legislation that was passed in 2018 called the Support Act, the Substance Use Disorder Prevention that Promotes Opioid Recovery and Treatment Act. Under this act, pursuant to this act, the Federal Department of Health and Human Services issued guidance to states in October 2020 regarding funding opportunities that exist to support family-focused substance use disorder residential treatment programs for pregnant and postpartum women. And those opportunities to fund those family-focused programs include flexibility under Medicaid, such as Medicaid waivers that would allow the receipt of federal Medicaid funding, use and coordination of Medicaid, Title IV-E, and SAMHSA grant funding. SAMHSA is the Substance Abuse and Mental Health Services Administration, to support those treatment services, and use and coordination of Medicaid and Title IV-E funding that would support the placement of children with parents who are receiving treatment in a family-focused residential treatment program.
Representative Wilson.
Thank you, Mr. Chairman. Donna, I'm not sure, again, if you know, you might need a department. Do you know, is the federal match for these waiver programs is the same as the usual 50-50?
I'm sorry, I don't know that, but perhaps the Department of Health would know under a waiver.
We're
how
getting
that
a
would-
thumbs up. I'll raise it for the screen. Thumbs up. Thank you, Director. Go ahead.
And that's the end of my presentation. If you have any questions, and I'll probably defer them to one of the agencies.
Chances are we'll probably get them answered here shortly as we bring some other folks up. Thank you very much. Thank you both very much. Ms. Somerville, would you like to be next in the hot seat? And just for a heads up, who will follow her? Let's follow her with the Medical Society. We'll follow Ms. Somerville. So get your notes in order. Welcome, introduce yourself and go ahead and Tell us what's on your mind, Ms. Somerville.
Thank you, Mr. Chairman. Andy Somerville, Executive Director for WAMSAC, the Wyoming Association of Mental Health and Substance Abuse Centers. And Mr. Chairman, I'm really here today to just talk about what is actually available for parenting women. So we consider pregnant women or women with very small children to be parenting women. And that's the language we use for those beds. So I really want to talk about what's available in the state right now and what that looks like. So on page 11 of the LSO memo, we provided information to LSO regarding the number of beds. We have 21 total parenting women beds in the state. Those are in Sweetwater County, Natrona County, and up in Sheridan. And I will tell you, over the last 2 years in COVID, the utilization of those beds has kind of ridden a wave, as all residential facilities certainly have. When we met for the session in March, one of those facilities had a 6-month waiting list. I will tell you, as of today, we have a few beds available in Cheyenne. We have no beds available in Sweetwater County and no beds available in Sheridan, with a wait list up there that's about 4 to 6 weeks. So again, that demand kind of ebbs and flows, but in general, trending over time, we see that those beds consistently have waiting lists. I also want to let the committee know that the beds in Casper are relatively new. Prior to this last fiscal year, those beds were adolescent beds, and they were transitioned to parenting women beds to help meet that need. So those beds in Natrona County are less than a year old in terms of being on service. In FY21, by my count, we have 94 parenting women that were served by the community mental health centers that provide this residential substance use disorder treatment. That's about 95% of what we can figure out for data statewide. And I want to make sure the committee understands these are all state contract funded beds. So these are state general funds that fund these beds, because Medicaid does not pay for SUD residential treatment. So essentially, we take everybody into these facilities and provide that service. Your community mental health centers provide a variety of services to these women, but often parenting women, when we assess them for their needs and placement, depending on their substance use, will often need residential treatment. These are women that may have high-risk complicated pregnancies. They need quite a few wraparound services. The SUD residential programs concentrate on not only the recovery and support of the SUD condition, but they support helping them find work, helping them employ things that will help them be more successful, working on education, finding housing if necessary. And then essentially those services wrap around long after discharge. As you would imagine, these women need quite a bit of support as they move forward to be successful, not just with their addiction issues, but also with just general social issues. If a woman in this situation, doesn't have housing or cannot find employment, et cetera, and cannot find daycare, for example, those things will all contribute to potentially relapsing with their SUD. So those beds are more specialized than what we would say typical women's residential beds are. Although women's residential beds, those are not pregnant, unaccompanied women that go into those beds. They receive a lot of the same services. The parenting women beds are more intense in services, if I can describe it that way. I would also just add, for talking with the director for the center in Rock Springs, they frequently have to take these women to Salt Lake for high-risk OB appointments and things along those lines. So their medical needs are pretty substantial as well. Not every pregnant or parenting woman will need residential treatment. Some of them will do just fine with intensive outpatient treatment. We provide those services, as do a variety of community providers across the state. But in our experience, most of them end up in residential care. We had a little bit of a discussion during the legislative session of what it would look like to meet the need when we talked about whether to put some additions to the criminal code in terms of criminalizing substance use. I just want to give a brief reminder of kind of what our assessment is as the providers for that. We would need an investment of probably somewhere between $8 and $10 million to meet that need. Now, that's a pretty big window. If we were to construct enough beds to serve the 113 additional women that were identified by DFS, we would probably need about a $2 million construction project to build it onto an existing facility in one location. If we built a new facility, that number goes up substantially. And then you have to take into account the operational costs and staffing and et cetera that would go into that makes up the rest of that. So while we have resources here on the ground, we do think that there is more demand in general. And I want to, again, COVID has been a wild ride for any residential facility, but we do think that there is more demand than we can potentially serve beyond what we're doing right now. And we would ask the committee, as you're looking at all of the things that you're going to hear about or have heard about, plans of safe care, our centers are involved in that project as well, putting that into place, to think about the resources on the ground for whichever area or pathway you go down. What we don't want to do is we want to help all of these women, but we don't want to create a situation where we have 3 to 6 month waiting lists, regardless of criminal or not criminal penalties. We just don't have the beds for these women to get served, because that won't help them achieve good outcomes. Now, I would just want to end my general testimony on a happy note and say that in just one of my centers in the last 10 years, they've had 94 babies born in the center that were brought in and born successfully with those women. That's just one center. I believe the one up in Sheridan, that number is north of 100. So these programs do work, and they do provide good services and help us keep a few more of those women and those infants off the mortality list. So with that, I would stand for any questions.
Thank you, Representative Ottman.
Thank you, Mr. Chairman, Ms. Somerville. I was just wondering, with these care facilities and with the option of extending one rather than building a new one, is the location of these centers based on larger population centers so that the opportunity for employment and services and that is more community? Thank you.
Ms. Norville.
Mr. Chairman, Representative Ottman, unfortunately, the answer is no. We do not have any of these beds in Cheyenne, which would probably be one. It's a relatively high demand county, and employment and recruitment is easier in a lot of veins in Cheyenne. They are based on what that community mental health center's needs assessment, what they feel the community needs and what's available for state funding. And then the third variable is, what can they find for capital construction money? How can they work with their communities to actually build the facilities? What's important to know about these actual physical buildings is that they're not built by state funds. They're not built by solely city or county funds. Well, I have to say with one exception, the agency in Sweetwater County is a county entity. So their stuff is a little bit different than everybody else. But for, Sheridan and Natrona County that have them right now, those are philanthropic campaigns to actually build the facilities. And so I wish I could tell you that it was. I think that the data that you saw in terms of where the high needs counties are is a great place to talk about. If we decided that the state wanted to invest in more beds, where should those beds go? There's some other variables to that as well. Does the community mental health center have additional land around them or space to build it onto their facility? That answer is going to be different for every community mental health center. And then the question of staffing, although that is not a topic for these two meetings, I'll just reiterate, it is very, very, very difficult right now to find mental health professionals at the master's and doctorate level. And I will add psychiatrist onto that. And I'm sure that several of the other folks out here in the audience would echo that sentiment. And so that's a very real logistical concern on the ground, is how would we staff those programs?
Follow up, go ahead.
Mr. Chairman, Ms. Somerville, so with the top 4 counties that seem to have a large population that needs help, while some of those are more metropolitan than urban, for instance, this county is more rural. Our towns are not that big. So what I was wondering is if that seems to be a population that struggle, will it be looked at to say, is this the best place to have that facility financially, or to get services for them, or to actually have them to be able to go out and be productive, to take classes, to go to work, to find daycare and all of those things? Is that a major consideration? Thank you.
Ms. Somerville.
Mr. Chairman, Representative Ottman, I think I'm going to try to answer that. And I think that those are important factors and they would be considered. And I would just say that any potential investments, whether it is on the community mental health side, through philanthropic or maybe potentially through state general funds, that absolutely has to be a partnership between that community mental health center and the Department of Health, because Department of Health is certainly the funding partner for us in terms of providing those services on the ground. I would also mention that in general, community mental health centers services, except for outpatient, are regionalized in this state, because we know that our smaller counties, such as the one that we're in, might not be able to support a full-blown facility in terms of staffing and having the number of clients it would take or the demand to make that facility feasible. And so we regionalize that. That happens in all of our residential care as well as our crisis stabilization. And so that would be a factor in those discussions too, is geographic distance and regionalization.
Go ahead, Senator McEwen.
Mr. Chairman, just kind of a couple quick questions. When we do the rehabilitation, what do we use as a factor that we define as success? And what are our success rates on inpatient treatment and IOP? Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Mr. Chairman, Senator McEwen, so I'm going to be able to answer a part of that, and a piece of it that I'm going to have to get back to you. So in general, just an average across the state, our success rate with inpatient treatment is usually north of 80%. Now, success rate is defined as a graduation rate, that they've completed the program, that their counselors and their professionals have agreed that they've made the necessary progress and have a good plan in place to transition into aftercare and potentially move out back into the community. What I will tell you, we do not track in this state is 6 months, 12 months, 18 months down the road. Is that person still in a sober living situation? Are they still being successful? We don't have that data, and I can't share that with you. And then in terms of intensive outpatient treatment, that is the number I will have to get back to you.
Follow-up. Thank you, Mr. Chairman. I think as we ask taxpayers to foot the bill for this, it's important that they know if it works or not. And I'm not trying to be obstinate, but wouldn't you agree an 80% graduation rate really doesn't indicate whether it's successful or not? Thank you, Mr. Chairman.
Go ahead, Ms. Somerville.
Mr. Chairman, Senator McEwen, I don't know that I'm well-versed enough to say that that is a good marker or not, but unfortunately it's what we have in the state is that's the number that I can give you. I can tell you that every provider would like to track that further down the road, but we simply don't have the infrastructure to do that long-term. But those longer tracking pieces are incredibly valuable to your point of evaluating programs. Are they successful? Should they be changed, et cetera? And we just don't have those.
The question's up there, Senator Hutchings' hand. Go ahead, ma'am.
It appears you like my hand better than the Zoom hand. So I'll keep raising my hand, Mr. Chairman. Mrs. Somerville, this whole process seems like it is an expensive, ongoing expense for maybe eternity, to have the state jump in and build a facility for women on drugs and paying for childcare with DFS. What is going on in our society? If you can maybe give me an idea, maybe the women that you guys are putting in these programs are telling you what's going on, that they see the need to be on drugs, especially when they're pregnant. And also when we've had a say no to drug program since, gosh, maybe 70s, 80s. Can you give us an idea what is the reason for these women to be on drugs, especially during pregnancy?
Ms. Somerville, go ahead.
Mr. Chairman, Senator Hutchings, I don't know that I'll be able to give you maybe as comprehensive an answer as you would like. To be fair, everybody has different thoughts on why those reasons are, right? And we try to study those, but they are somewhat abstract. Certainly reasons that I have seen and read in literature range from, family situations. Drug use is usually pre-existing to the pregnancy. Financial pressures, stress, criminal activity. I mean, it runs the gambit. And I would certainly defer to any of the providers that are sitting behind me that have actually worked with these clients to provide some additional information. So I apologize for not being able to answer that as well as you would like.
Thank you, Mrs. Somerville. Mr. Chairman, may I have a follow-up?
You may go ahead.
Again, going back to the prenatal treatment that we're giving to these women, it seems as if we're providing that, we could maybe limit or reduce the number of women that go on to need substances or use substances by the time their child is born. Would you say that that's something you guys may be looking into during the prenatal treatment phase, making sure if these women are on drugs, they get off drugs before the child is born? Because now you have 2 victims instead of 1 that the state is paying for. Thank you.
Ms. Somerville.
Mr. Chairman, Senator Hutchings, I would say generally, yes. So when you're working with this population, it's not just about the substance use providers, whether it's residential or intensive outpatient treatment. I think as you're going to hear in the speakers after me, it really is a collaboration between the primary care physicians, the OBGYN, in terms of identifying these things as early as possible, and offering that patient some options for treatment and trying to help them move forward and be successful. We certainly want to try to limit substance use during pregnancy as much as we can, but depending on what is going on in their diagnosis, that's going to be different for every woman. There are some women that can be on medication-assisted therapy throughout the pregnancy to remove that substance as well. So I would say that all of those things are really important. And what we're working on right now is a group with plans of safe care. And that is trying to create some definitions and a plan of what types of providers, what types of screenings, what do we do when these screenings show something, maybe an infant is exposed or affected potentially by substance use. What does that look like? That's a really important first step building block to be able to identify how we get to these women as early as we can that are pregnant. And then what do we do to help them down the road and support them going forward? And I would just also add that that work is still, I mean, it's in early stages and ongoing.
Okay. Go ahead, Chairman Wilson.
Thank you, Mr. Chairman. Andy, going way back, so I wrote down that you had 94 women served in 2021. And then I think you cited a number maybe from DFS on the hypothetical additional number to be served. I didn't find it in paper, so could you give that to me again?
Mr. Chairman, Madam Co-Chairman, that was 113 additional women.
Thank you.
Further questions, committee?
Mr. Chair,
I believe Representative Conley.
Yeah, thank you, Mr. Chair. Ms. Somerville, I'm really intrigued by actually the new group that you said that you're working with, as well as the notion of increasing existing facilities to accommodate the need that's being talked about. And I'm curious if you have thought at all about any of the opportunities that are available with still existing ARPA money. And if you could talk to us a little bit about that.
Ms. Somerville.
Mr. Chairman, Representative Connolly, absolutely. So that, just in general, I'll say we are going through a behavioral health reform process, as you'll hear later today. This is one of the categories that we serve, and certainly part of the discussions, but we want those discussions to be a partnership with the Department of Health. So with Senate File 66, there was $7 million set aside for women's residential specifically and crisis stabilization. So those conversations about additional women's beds or potentially parenting women beds is certainly going on, and there is a little bit of money through the ARPA bill to move that forward. And I also just want to add, in terms of plans of safe care, there's a number of providers, the Hospital Association, medical society providers. This is a very large collaborative group that is working on that plans of safe care piece. So yes, we are working on those. I believe that there will be some proposals potentially coming forward for some capital construction money, but I would also say I'm still waiting on the final SLIB board rules to see what the eligibility requirements will be and whether we'll be able to make the match requirement from the local community mental health center.
Mr. Chair, and just say I appreciate your deliberative process, but I would hate to lose an opportunity that's before us. Thanks.
Thank you. Further questions, committee? See none. Thank you very much, Ms. Somerville.
Thank you, Mr. Chairman.
That brings us to Wyoming Medical Society.
Mr.
Oh,
Chairman.
Senator Hutchings. I'm
just
sorry, I
one-
should see your hand, but go ahead.
Boy, I almost lost, I lost the question. When I get it back, it'll be for Mrs. Somerville, and maybe I'll talk to her offline. Thank you.
Okay. Okay, Wyoming Medical Society. At the completion of this portion, we'll go ahead and take a break and give Wyoming Hospital Association a chance to warm up. Welcome to the committee, Ms. Bush. Introduce your guest.
Good morning, Mr. Chairman, members of the committee, Sheila Bush with the Wyoming Medical Society. And this morning with me, I have Dr. Mook, who's a local practicing pediatrician. I think she has a lot of really meaningful information to share with you and can also answer a lot of the questions that have been asked. So I will turn it over to her.
Go ahead and introduce yourself and welcome to the committee.
Thanks, Sheila. Good morning, Mr. Chairman and members of the committee. As Sheila said, my name is Louisa Mook, and I'm a pediatrician with experience in the care of newborns who are born to mothers with substance use disorder. I completed my medical degree at University of Vermont in 2013, my residency in pediatrics at University of Washington Seattle Children's Hospital in 2016, and completed an additional chief resident year in 2017. Since then, I've been practicing rural pediatrics, both in inpatient and outpatient settings. I've been a physician at Fort Washakie Indian Health Service Clinic since early 2020. I also take pediatrics call at Sage Westlander Hospital. The majority of my work in the hospital is in newborn nursery care, where I attend high-risk deliveries, stabilize sick infants, and care for both healthy and sick newborns. I'm working hard to improve the health of babies in our state, especially when it comes to drug exposure. At Fort Washakie and in the hospital, we use the most current evidence-based protocols for screening and treating infants born to mothers with substance use disorder. We hold weekly multidisciplinary team meetings on the Wind River Reservation in order to track and coordinate social services and medical care for high-risk children, including drug-exposed children. I'm also part of a collaboration with child abuse and neglect specialists at Primary Children's Hospital in Utah and Colorado Children's Hospital, the two medical centers where we send children whose medical needs exceed the care that we can provide locally. The collaboration's goal is to improve medical care for high-risk children, including drug-exposed infants in regions with more limited pediatric medical resources. I'm also part of the hospital pediatric OBGYN committee that reviews and improves maternal child care in the hospital setting. I'm going to walk you through a typical hospitalization for a pregnant woman with substance use disorder when she has her baby. There have been a lot of questions asked about this, so I hope it's helpful. When there's a known substance use disorder, poor or no prenatal care, or a positive prior urine drug test during pregnancy, women in labor are assessed with a urine drug test. The results are typically back within 24 hours. Then when the baby is born, we also test the baby. These results can take up to 14 days to come back depending on which test is used. The drug test done on the baby evaluates substance exposure at least back to the start of the 3rd trimester, so it gives more of an overview of what's occurred during the pregnancy. If the mother's urine drug screen is positive at the time of the delivery, the baby's physician discusses the results with the mother and notifies the Department of Family Services. The hospital care that the infant then receives depends on which substance the baby was exposed to. Opiate exposure triggers a withdrawal screening protocol and often a longer hospitalization. Sometimes babies withdrawing need to be transferred to a higher level of care for treatment of withdrawal with medicine and a more specialized nursing team. But most often, because our current protocols babies do very well and can stay in Wyoming. If the physician thinks that it's unsafe for a baby to go home with its mother, they will write a protective custody order, which removes the infant from the mother's care for at least 72 hours until a court hearing takes place. Whoops. After the protective custody order is written, what happens to the infant is out of the physician's hands and is determined by DFS, the court, and whether corrective action by the mother has been taken to regain custody. In every other state that I've practiced in, and in the states that I collaborate with, this process is actually left to DFS. I think it's better left in DFS's jurisdiction. As physicians, we don't always know what resources or safety issues exist for a mother, and we don't do home visits to assess safety. If a physician does not take protective custody, they must develop a plan of safe care. This looks different for each mother-infant pair, but generally it involves frequent clinic visits to monitor the baby closely. DFS also typically continues to do home assessments, and sometimes caseworkers work with a mom to facilitate treatment, drug testing, or other monitoring. It is my opinion that as a state, we could be providing these mothers and their babies with more resources, and we could streamline the plan of safe care. For example, we could make templates available to physicians that outline a recommended clinic visit schedule, safety contract language to use with the mom or other infant caregivers that are involved, support service options, and other resources that might be helpful. We could have physicians with expertise in the field available for consultation on this process as well. Currently, DFS is underfunded and often unable to partner with physicians sufficiently to provide the wraparound services that drug-exposed infants really need to thrive. Outcomes for infants who have been exposed to substances varies by the substance. As a physician, I first consider the short-term impact and then the long-term impact. We know that babies exposed to opiates can undergo withdrawal after birth that can be severe and life-threatening. Babies exposed to methamphetamines just before delivery are affected by the drug itself, but there isn't as clear of a withdrawal syndrome as there is with opiates. These are the short-term impacts that we monitor for in the immediate postpartum period. The long-term impact of substance exposure is really hard to study because there's so many factors that influence child development. It's difficult to isolate the effect of one substance, and often there are more than one substance used. Addiction, ADHD, and other disorders also have genetic predisposition, so it's hard to say what effects in a developing child are from drug exposure, genetics versus their environment. Heavy alcohol use in pregnancy is actually the most harmful to children long-term. Alcohol impacts or pickles the entire brain. There are decades of research supporting this, and even a medical diagnosis called fetal alcohol spectrum disorder. The long-term impact of opiate and methamphetamine exposure in utero is actually less clear, and the effect of these drugs on the brain is more localized. Some studies suggest slightly lower scores on tests assessing child's development and slightly higher rates of ADHD-like behaviors. The primary physician of any drug-exposed infant should be performing frequent developmental screening with prompt referral to early intervention services as needed. And then as the child enters school, they may need more specialized learning assessments. I think care of drug-endangered children would be improved by identifying physicians and communities with experience and expertise in the field. Other physicians and child care providers could then refer to these more specialized providers. Multidisciplinary meetings with physicians, DFS, and other community partners would improve communication and create a better safety net for these children. Hospitals throughout the state should be using the eat, sleep, console method for screening and treating babies with opiate exposure. This protocol has been shown to decrease the length of hospital stay, decrease the need to treat these babies with morphine, and reduce the number of transfers out of the state. The Eat, Sleep, Console protocol also improves maternal child attachment and bonding, which is critical to a baby's health and development. Improved DFS staffing and training and access to substance use disorder treatment would also make a big difference. Finally, I want to directly address potential legislation to criminalize mothers who use drugs during pregnancy. Criminalizing these mothers does not make babies any safer. It actually harms babies. It makes pregnant women with addiction avoid important prenatal care due to fear. Criminalization is not an effective deterrent to substance use. The research backing this up is so strong that every medical society with expertise in maternal child health explicitly recommends against it. This is even more important in our state. We are unique in that we do not have a children's hospital or any pediatric subspecialty care. Every baby that I need to transfer requires a flight out of state. This is cumbersome, dangerous, and costly. We try to keep babies home, but sometimes we can't. Then neonatal ICU level care is being performed by rural hospital staff doing the best they can until a transport team arrives from a children's hospital. Clearly, we want to avoid having pregnant women who have had no prenatal care show up to the hospital in labor. When these high-risk deliveries occur, we do not know if the baby's premature, if it will be able to breathe on its own, or if it has a medical issue like a heart, stomach, or spine defect. We have a growing problem with methamphetamine use in Wyoming. I am seeing a large increase in women showing up to the hospital with no prenatal care who have been using methamphetamines. We know that criminalizing these pregnant women will not stop them from using drugs, but it will stop them from going to the doctor. We need our clinics and our hospitals to be safe places for these women so that babies can have the best chance at a healthy start. Any legislation that deters women from getting prenatal care will hurt babies the most. And I will say, to also end on a positive note, when treatment works and women are able to keep their babies, it is one of the most powerful and rewarding clinical experiences that I've had in my somewhat short career so far. And so I think as a state, the more that we can be supporting women to help their babies thrive is the best possible thing for babies in our state.
Thank you very much. Questions, committee? Representative Bachman.
Thank you, Mr. Chairman. What I was wondering is at the very beginning with the testing, is that testing, the mother can choose whether or not to be tested?
So it's important that moms consent to drug testing when they show up to the hospital. This works in a lot of different ways because sometimes women are showing up in precipitous labor and there's actually not time because the baby is halfway out. So it really depends on the clinical situation, but in an ideal world, what I do as the pediatrician on call is that if I have a concern about no prenatal care and there's time, I'll just talk to the mom about it because often we don't actually collect the urine sample until after the baby is born. And I really believe in taking a direct approach with this and saying, you know, when women come to the hospital and they haven't had any prenatal care, we do a urine screening as part of our protocol. What happens with that, I will discuss with, you know, the results with you. The drug screens aren't perfect. And so there are a lot of situations where there are false positives. And then it's also really important to consider what prescriptions have been prescribed by a doctor. So if a woman tests positive for an opiate but received a fentanyl injection during their labor, you know, it's really important that you're not making a mistake and accusing a woman of substances that were actually prescribed by her physician. So it's a pretty nuanced conversation. And usually I wait for an opportunity in the hospitalization where there's a little bit of downtime where I can really have an honest conversation and explain why I'm getting the test and that I'm really doing the best I can to make her baby, you know, the care of her baby as safe as possible.
Follow up, go ahead, Representative.
Thank you, Mr. Chairman. So the test though is with consent and the care is not taken away if they do not consent, is it?
Correct.
Thank you.
Go ahead, Representative Conley.
Thank you, Mr. Chairman. First, thank you, Dr. Mook. And the work that you do sounds both incredible for our state, but mostly for the moms and the babies. And I so appreciate it. I want to go back to the presentation by the Department of Health. And and the committee that was looking at kind of maternal and infant outcomes and related to access to care. And I'm curious if you have any kind of experience, anecdotal evidence that you can share with us regarding, that access to care, prenatal care in particular, and income. Anything you can share with us along those lines? Because there was a little bit of kind of conversation about, is there really an issue regarding individual mothers getting prenatal care and Medicaid and insurance and anything along those lines?
Go ahead, doctor.
Thank you for the question. I think that's another nuanced conversation. The getting health insurance is a bulky process for people. And so going through the different avenues to apply for Medicaid or get help with that process, I do think that women with less financial means have a harder time with transportation, with navigating some of those systems. Some of the patients I take care of don't have, working internet, working cars. And so I think that there are a lot of barriers to getting care that exist for women who are pregnant, and that those are very true for impoverished women in our state. You have to drive really far to do anything here.
Further questions, committee? Go ahead, Representative Slender.
Mr. Chairman, thank you. And I don't know who can answer this, but how effective are we as a state in assessing and diagnosing women in pregnancy with abuse problems and trying to arrest that before the baby's born?
Doctor, go ahead.
I can answer that more anecdotally than with data. But I would say that for women who are accessing prenatal care, that's done pretty regularly. I think that there has been a really big increase in women not accessing prenatal care. And quite honestly, I don't actually know what's been driving that, but we've had a really, really sharp increase of women showing up to the hospital who have not had prenatal care. And then, the clock is kind of starting at that delivery for the 60 days of treatment access. I will say that early newborn period is one of the I've never met a mom who doesn't want to do better by her infant in that 24 hours. And so it does feel like, even for women who haven't had prenatal care, it's a really critical window for motivation, for change, and just really a moment to really have time to connect with a patient and help them access services. I don't know if that quite answers your question.
Thank you. Further questions? Go ahead, Madam Chairman.
Thank you, Mr. Chairman. Thank you, Dr. So 2 questions, and one of which you addressed a little bit, but so we earlier heard that overall, nearly 87% of the pregnant women in Wyoming get prenatal care starting in the first trimester. And I realize this is maybe a little anecdotal, but in your practice here, is there a significant difference with women who are abusing various substances? I mean, do they typically show up, in the early second trimester or the last 2 weeks, or is it all over the place?
I think it's all over the place, but I do think that having no prenatal care often for me is a sign that something else was going on in their pregnancy, some other mental health disorder, substance use disorder. And I also wonder if those statistics are from prior to COVID. I think in general, access to care has decreased in the last 2 years. And so I wonder if across the state, those numbers would be lower. But I do think that women who have active substance use disorder that is not in treatment tend to have lower rates of prenatal care.
And follow
up, go ahead.
Thank you. And so the second question, actually, it's not technically a follow-up, it's a different question, but earlier we looked at some data, again, from Department of Health. They were estimating the number of newborns diagnosed each year with substance abuse withdrawal based on Medicaid claims data. Now, your practice here, I suppose, is maybe 50-50, or, I mean, you know, depending, but do you think that the Medicaid newborn substance abuse population is the bulk of it, or do you think the substance abuse problem is fairly evenly distributed across insured type of person, or do you have any thoughts on that? I mean, I'm just trying to, you know, look at the numbers. I mean, if we're looking at 50 to 75, should I double that for the state, or just push it up a little, or any thoughts on that?
I would say double. I think, you know, in our conversation earlier about how those numbers come to be, it sounds like it requires a diagnosis like neonatal abstinence syndrome to be on the baby's chart. And I think anecdotally about all the ways that I classify substance use in utero, and I feel like a lot of that's being missed regardless of insurance status. So if a woman, if I, you know, see from her 20-week visit that at that visit she tested positive for methamphetamines, I don't know that that gets on. I mean, I try to be careful about documenting, you know, methamphetamine exposure, but a lot of times the ICD-9 codes are not to date, and that's actually not a code that I can put on. And so then I have to find some other like high risk infant or some other code to sort of capture what I'm trying to describe clinically. And so I would just use some caution around the numbers that are given there. And I also think that opiates, anecdotally to me, seem like they're a lesser part of what we're seeing right now. And so, you know, I'm curious as to how methamphetamine exposure is being captured in the data.
Thank you.
Very good. Dr. Hallinan.
Thank you, Madam or Mr. Chairman, and our distinguished guest. I would ask, have you seen any problem with the marijuana in these infants? Thank you.
Dr. Duck, go ahead.
Thank you. It's a great question. It's been interesting as a pediatrician with the legalization of marijuana, because across the country, rates of marijuana exposure have gone up. There are still not great studies as to how marijuana exposure impacts infants, and that's true for pregnancy and breastfeeding. But there are thoughts that, you know, that there are some detrimental effects potentially, but the studies really aren't great. And now that there's more legalization, I think the studies will follow that we can actually study it a little bit more. We know that marijuana concentrates in breast milk. So I have really frank conversations with my breastfeeding moms about marijuana use during breastfeeding in particular, and in pregnancy if I know the mom ahead of time. But I think the research on it is still lagging a little bit behind the legalization, and now that the use is so prevalent.
Further questions, committee? Go ahead, Representative Worf.
Yes, Mr. Chairman, I guess, Dr. Mook, one of the questions I have is, how would you recommend that we provide help to these mothers that are using? I know there was a bill this year that I spoke against just because I was aware of some of the data that you mentioned, but I guess that's one of the questions. I know it's coming back, and I just wonder, somebody that deals with that, what would you recommend is the best process that the state could proceed with as far as trying to help these mothers that are in a situation where I'm assuming most of these pregnancies are unplanned. So how would you best recommend that we address this? Go ahead, Doctor.
$1 million question. I think some of the things that I've been thinking a lot about in preparation for today are really about streamlining the way as a state we create these plans of safe care and sort of bring people together around these mothers and babies. The more we can keep babies with their moms through this process, the better for babies by far. And there's a lot of success stories with the opiate crisis, with that happening in the medical field. And so I think the more that we can sort of work together with the different organizations that end up sort of touching these women at various points in their pregnancy and postpartum period. I do think having a longer period of postpartum healthcare coverage, 60 days is really short, especially for the women who are presenting to care at time of delivery. And so I do think that would open up doors for more services, because when women lose Medicaid, they typically sort of retreat back and stop getting medical care. That collaboration that I've started with other children's hospitals, like I really think reaching out to some of our partners and creating more of a network across rural states is helpful, since we rely on states for some of the medical care that Wyoming doesn't provide, especially I'm thinking of pediatrics. Yeah, I'd be open to a lot of other ideas. I really do worry. I mean, as a pediatrician, when I get the phone call that a mom's showing up with no prenatal care, that's the worst call that I get. And so anything that's going to make moms not want to come to the doctor is something that I just really, really worry about for the safety of babies, because I want to know what's going on with that baby before the delivery starts.
Go ahead, Representative Bob.
Thank you, Mr. Chairman. I was just wondering, is there any way that we could loop the Department of Health into this for education, or is that? And thank you for everything. I really appreciate your care and consideration in looking at the situation and not just a person. Yeah.
Go ahead, Doctor.
I think that's a great idea. And it's actually something I've been considering on the reservation, is really trying to do more outreach about the importance of prenatal care and making it more known what substance use disorder treatments are available. I think women who have substance use disorder are also often afraid of accessing care. And I think the Department of Health often has more like on the ground resources that aren't part of like the medical establishment. And so I think partnering with them has a lot of potential, especially with public health nursing and with DFS as well.
Thank you. Representative, go ahead.
Thank you, Chairman. Dr. Mook.
Yep.
I just want to thank you for what you're doing for the reservation and her people. I have a couple of questions. Is there more of pregnant women delivering cesarean versus vaginal? And then the babies that you have to fly out, where are you primarily flying them to? And then has any of the pregnant women talked about, and I'm glad for my colleague here bringing up the issue of marijuana. And so, speaking to constituents and our customs and our ways as Indigenous people, we talk about traditional ecological knowledge. So we look at medicinal plants. Has any of the pregnant women talked, personally about their personal freedoms and their liberties? And this is my personal choice, and this is what I believe in. And I believe that, marijuana, is my right medicinally under the guise of that traditional ecological knowledge framework.
Go ahead, Doc.
Those are great questions. The first part, so in terms of babies being flown out, I don't know that anecdotally I've seen a big difference between the C-section and vaginal delivery. Often, a lot of the women who are using methamphetamines come in and deliver vaginally, in my experience. Methamphetamine use can actually precipitate labor because it causes the blood vessels to constrict. Of course, an emergency C-section where something's going wrong, there's a higher chance that the baby might have to be flown out in that situation. Primarily, we're flying children to Primary Children's Hospital in Utah and Salt Lake City, and then Colorado Children's Hospital in Denver. There's another hospital called Rocky Mountain Hospital in Denver that has a great NICU, and they've done a lot of outreach in our area, so we use them as well. And then your question about marijuana. I've only been at my job for 2.5 years, and so I'm just now starting to have patients who I think feel comfortable talking to me about their more traditional ways. I haven't had a lot of conversations around marijuana specifically with that. But I have with, especially with COVID, I had a lot of women who are breastfeeding who were asking me about other medicinal, treatments for COVID. And of course, we just don't know a lot of the safety data for babies in those situations. I haven't really, I don't know if it's just my approach with marijuana or if it's the way that my patients think about it, but I actually haven't had a lot of people feeling like it's their right to smoke marijuana, but I'm also not telling them that that they shouldn't always, like I'm trying to have a conversation about why they're using marijuana. And I definitely have a lot of moms who use it to treat anxiety. And so I often more have the conversation about maybe safer alternatives or, why they're using marijuana and other medications or treatments that might be, have like more data to support the safety benefits for their babies.
Follow up, Mr.
Follow up,
Chairman.
go ahead.
So with research, in your experience, when we talk about just, drugs in general, the 30,000 foot view of drugs, in your opinion, is marijuana right up there with a strong, narcotic in general as a medicine, for coping mechanisms, whether that's pain or the anxiety? And then in your assessment, speaking with these pregnant women, how much does the intergenerational trauma affect them?
I think the intergenerational trauma affects them a lot. And the patients that I know well talk a lot about that. As a clinician and scientist, and after the training that I've been through, I actually really try not to reserve judgment on what medication's worse until I see the data. So I honestly don't know the answer to marijuana, and that's kind of what I say. There are some pediatricians who outright say, like, if you're going to use marijuana, you should not breastfeed. I don't feel like the data is strong enough to say that. I actually think that alcohol, out of all the substances we've talked about, is the most detrimental to the growth of a child. And so that's the substance that I actually counsel most strongly about for pregnant women. But I really, on marijuana, I try to give my best, best advice that I can based on what research we have, but I have sort of saved judgment since I'm not sure yet.
Another follow-up, Chairman. Are you, to your knowledge, in the healthcare system with Fort Washakie, are you having a conversation as that organization, including working with our elders, the societies, the groups that we have out there, and getting their knowledge as far as healthcare with our pregnant women? Are you having conversations with our elders?
I personally have not, but we have some new leadership right now who are, I think, really motivated to do more bridging with the community from our healthcare clinic. I think in the past, it's been a bit more siloed. And I would love to chat with you at some time about the best way to do some outreach with women who are pregnant or of childbearing potential, and potentially collaborating with elders. I think it would be great.
One more follow-up question, Mr. Chairman.
Go ahead.
In your assessment or your experience in the medical field, yourself or with colleagues, just in general. So women that are suffering, with substance abuse during pregnancy, do they tend to get a label, a reputation among the medical community that prevents them from access, that prevents them from, a true quality, I heard the term wraparound services. Are they discriminated against? Are they looked down upon? Or, does that affect them?
Go ahead, doctor.
There's very strong data suggesting that yes, that happens and it affects women, and that it is one of the reasons that they don't access care. I am probably biased, but I think at Fort Washakie, we're trying really hard to bring those women in. I think we have a really phenomenal group of providers who are trying to break some of that stigma down, because we know that when women access care, their pregnancy and their baby will be healthier and they have a higher chance of, getting treatment. But yes, nationally, that's true.
Ready for the questions? Seeing none, I would just throw in one additional observation since we've kind of broken the ground there about marijuana, and you probably can concur this. When we discuss marijuana use, marijuana effects, well, it's evolving very quickly. As opposed to my patient that comes in, which I don't see anymore. My patient came in that smoked marijuana all the way from their home, an hour and a half away from my office. That's one marijuana use. And that was the pain control, nausea control. As opposed to the patients that I've seen, just say this last week, my teenage kids that come in who are dabbing marijuana, which is much more powerful, as high as 10 times the concentration of what these folks are getting in smoke, much more dangerous in the wax and in the crystal formation that's being distilled via butane, et cetera, which is a chemistry class by itself. But the effects of that are approaching the effects of methamphetamines. And potentially, I suspect that in the newborns and in our fetal population, that we're going to see that some of that proceed through. So it's an evolving thing, and not just that, we're seeing it infused with fentanyl, et cetera. So it's an evolving thing, and will continue to evolve. It's much more dangerous, much more than what we used to see. But I don't know if you have any comments on that, Doctor.
No, I would agree. I think that's part of the reason it's so hard to study is that it's changing really quickly.
When I used to think of people talking about marijuana for not, et cetera, I just think about the guy smoking a joint. It wasn't such a big deal, and that's not where we're at now. That's not where we're at all. So, with that said, thank you very much for your testimony. You let Ms. Bush off the hook. She didn't have to hardly talk. It's maybe good, it may be bad. Let's take a 10-minute break, and we're going to come back and hear from the Hospital Association. We're behind schedule, but that's okay. We anticipated we would be. We've got one topic on the afternoon, which won't take as long as we have scheduled. So take a 10-minute break. Let's be back here at 25 after. Don't you always just want to throw this gavel at some people? Okay, committee, we have up before us Wyoming Hospital Association, following which we will have some public comment. So go ahead and introduce yourselves and tell us what's on your mind.
Morning, Mr. Chairman, committee members, Eric Boley, President of the Wyoming Hospital Association.
Mr. Chairman, members of the committee, Josh Hannis, also with the Wyoming Hospital Association.
We were invited here to kind of talk about a couple of issues that are going on and maybe to provide some comment about reporting and where we might be able to get better data and better information. The information that you received from the LSO came out of a database that we actually use. It's called HIDI. It's the Hospital Industry Data Institute. And it gives us discharge data. And it can actually be drilled down by zip code. And as I looked at the statistics, I'm not sure how they were accumulated, but it makes sense that we see large numbers in some of those areas. But I would imagine as we drill down and look at zip codes that they may be residents from other counties that come to Natrona County or Laramie County, some of the larger communities, Gillette, Campbell County to have deliveries. Also, in some of those areas up in the northeast corner of the state, we have 2 critical access hospitals that don't do deliveries in Crook County and in Newcastle. So I would imagine that a percentage of the deliveries that take place in Campbell County come out of those 2 counties. Lusk is another one of our critical access hospitals that doesn't do labor and delivery. And then as we get up into Bighorn Basin, Lovell and Basin Hospitals, South Bighorn, well, 3 Rivers now, they don't do labor and delivery. And so the numbers would probably be skewed a little bit with those. And now we'll talk about this a little bit. We have 2 new critical access hospitals that just recently announced that they will no longer be doing labor and delivery at South Lincoln Medical Center in Kimmer and then at the hospital in Rollins. And we'll touch on why that's happening. I think we do have some opportunities as far as reporting is concerned. All of our hospitals, all of our clinics now are on electronic health records. And a lot of the data I think that we're trying to gather is available through those EMRs. And then as you're aware, the state is established and set up a health information exchange, which is a repository and can draw data from all of those people that are inputting data. Currently, we have 17 of the 28 hospitals in the state that are already interfaced and are submitting data. I think all of the Medicaid patients are actually, all of the Medicaid patients should be in the HIE as well. And we're in the process of trying to get the other remaining hospitals tied into the health information exchange. We'd have to take a look probably at how the data is gathered. We want to make sure that there are no privacy concerns or anything like that. But I do think that that might be one of the areas that we could focus on to get better data. The other thing is we listened to testimony today and as we look around the state, it's good to see that there are reports going out to DFS to report mothers that may have a substance abuse problem so that we can take care of those babies. I would venture to guess though that reporting is not static and it's not done the same in each facility and by each provider. And so I'm not sure if those numbers are really what they should or could be. And some of the issues that we run into, as was discussed by the doctors, there's a lot of prenatal care that doesn't get taken care of. And we immediately have a mother that, an expectant mother, arrive at our ER and she's in labor. So we haven't had any time to do prenatal. We also have midwives in the state that may or may not be doing prenatal care. They, to my knowledge, don't have electronic health records. I'm not sure what reporting requirements there are. A lot of times we won't see those in our hospitals unless something goes bad with the delivery, because there are home deliveries. And so I just think there are a lot of nuances that we have to consider as we look at how we're going to gather this data. There has been quite a bit of work done, and Josh actually serves on a couple of different committees that he's been working with, and I think he wanted to kind of share a little bit of what they've been doing too.
Mr. Chairman, I really just have two things. One, you've already heard about a little bit, the plans of safe care effort that's happening now. We as an association serve on one of their committees, and then representatives from our member hospitals serve on their various committees and are part of that work. A number of those partners are here in the room today. And like I said, you've already heard about it. Really that goal being, how do we consistently implement a public health model and support and help around mothers who come in who have substance use disorders, and how do we support them and their babies to keep them together and out of the foster care system. The other one I just wanted to bring to your attention is what's known as the Chosen Quality Improvement Collaborative. This was a group started with a number of funders, including the Colorado AG's office and some philanthropic organizations, to create a quality improvement collaborative around dealing with pregnant women who have substance use disorders, and how do you support them and their babies. We have 6 Wyoming hospitals that participate in this, and their participation comes with resources for providers, for the hospitals, for the mothers. There's data sharing among those in the collaborative around implementing best practices and some data tracking. And so we do have a number of our birthing hospitals that participate in that as well. While not the same as the plans of safe care, there's certainly some overlap, and creating sort of a scaffolding of support as they treat these women and their babies.
I think, Mr. Chairman, the thing that we would say is we want the outcomes to be the best that they can be from a hospital perspective, and that has a lot to do with the providers as well. We want the mothers to be healthy. We want the babies to thrive. And some of the concerns that we've heard with reporting and potential legislation, we have some concerns that it'll actually dissuade mothers from seeking prenatal care, which is vital in making sure the babies have good outcomes. But we're willing to work in any way we can with the legislature to try and find ways to have the best outcomes we can in our state. I touched briefly because I know it's important, and it's kind of a curiosity, or not a curiosity, but it's an important topic with what's going on with our critical access hospitals in the state. And I think the thing to realize is what we're seeing in our state is a bigger picture of what's going on nationally. It's becoming harder and harder for our critical access hospitals in ways to deliver OB care. And there's a lot of different reasons. And I think you've probably seen the newspaper articles about why Rollins has decided to do what they're doing. There's newspaper articles on why Kimmer decided to do what it's doing. The numbers have really decreased. We looked at the numbers of deliveries that were taking place, and I can speak to Kimmer because when I left, we were doing around 60 or 70 deliveries a year. They're down to less than 20 a year. And so it really creates a situation of concern when the providers aren't seeing as many patients. They're not, it takes repetition to be good at what you're doing. And we had situations there where we were able to work with some of the bigger facilities down in Utah and allow providers to go and spend a whole week and do a ton of deliveries, because Utah is a baby factory. We could send our nurses down there and do it, but it's become harder and harder. And I think during COVID, that cross training has even been more difficult because they just couldn't leave, and there were different requirements for going into other facilities. So they're having trouble with staffing in our critical access hospitals. The nurses float from one department to another. You don't have dedicated staff just for delivery. You know, they go to ER, they go to inpatient, they take care of surgery, they take care of deliveries. And so having trained staff that are comfortable is an issue. We've also seen a huge staffing shortage. We're seeing that, and I think we'll talk about it again tomorrow when we talk about nursing homes. But it is a real issue, and that's really what's impacted Rollins in their decision. They have so many travelers in right now. They've blown through all of their reserves, and they actually subsidize and lose quite a bit of money on an annual basis in delivery. Now, whether the decision is right or wrong to stop that service, that's a whole different debate, but I can tell you the reasoning behind it. The other thing that we're seeing is family practice doctors. A lot of them don't want to do deliveries anymore. And most of our small facilities can't afford or really justify having an OBGYN on staff or two of those. And so it falls on a family practice doctor to also do deliveries. And a lot of RFPs that come out don't want to do that. There are others that will, and I'm pretty sure you're going to hear from one that is very interested in that. So it takes the right person in those situations to do it, but then they have to have the support staff and the training that's necessary. The other thing to consider is if the baby goes bad and we have to do an emergency C-section, it changes the whole dynamic of things. And there are facilities in the state maybe do 1, 2, or 3 C-sections in a year. And it's a very different animal than it is doing a regular delivery. And so you have huge overhead too. You've got to have respiratory therapy for either delivery, either type of delivery. You've got to have anesthesia. You got to have nursing provider, OR staff, and they've got to feel comfortable in that. It's the worst thing that can happen is you end up with an emergency C-section and things really go bad and you don't have the trained staff to handle that. So there's a lot of things going on in these 2 critical access hospitals. Compound that with the others that have already decided not to do it and haven't been doing it for many years. It's just a sign of what's really happening across the country in rural healthcare. I have concerns when we take a look at what's happening in those communities. If we take a look at Rollins, you know, it's 100 miles one way to Laramie, it's 100 miles to Rock Springs, 120 miles, I think, to get to Casper. And more times than not, that interstate's closed in the winter. So there's concerns there. They've done a great job in partnering with Ivinson Hospital, and Ivinson will be providing the prenatal care and doing everything up until the delivery in Rollins. So they've created that partnership, but then the deliveries will be done in Ivinson. And I know for a fact that Sweetwater County was going to reach out to Kimmer and see if there might be something that they could do to partner and help them in their situation. I don't know if there's a silver bullet here, if there's a right answer or a wrong answer. The decisions weren't made lightly. It was discussed at length and the boards made those decisions. But it does obviously create some concerns. And I would venture to guess that when Pinedale is built, they probably won't do deliveries there, nor will Saratoga. I can't say for sure, but I'm just guessing that those would be 2 locations that probably wouldn't do OB. So when you take a look at Lincoln County, you know, you've got LaBarge, Big Piney, Pinedale, that whole area. They've got to decide which route to go. Do they go to Jackson? Do they go to Rock Springs? And it's a long distance without Kimmer, or do they go to Evanston? And again, that's an area that's really high in altitude and they get a lot of snow and have some bad roads too. And so it's created some areas of concern for us, obviously, in the state.
Okay, questions, committee? Go ahead, Ms. Erin Wilson.
Thank you, Eric. So just out of all the communities in Wyoming that have hospitals or don't, how many hospitals in Wyoming after this change will be doing labor and delivery, as far as they know? I mean, I know there's always the unanticipated event, but what's the
Mr. Bowley?
Mr. Chairman, Madam Chairman, we'll have 20, I believe, that'll be out of the 27 acute care hospitals.
Further questions, committee? They're all getting hungry. They're very quiet. Okay, any further thing you'd like to say? Josh, Eric?
No, I mean, we're anxious to work on solutions. I do believe that one of the things that we would encourage the board, Mr. Chairman, or the committee to think about is this shortage that we have in healthcare workers. And one of the reasons that Rollins talked about, we're not back to normal levels yet. The CRMC still has over 100 travelers in, which is a staggering amount. It's costing them close to $4 million a month in travelers. Rollins didn't have any travelers, but now they've had to bring travelers in, and they're paying more than double what you would normally pay for a traveling RN, and it's blown through their reserves. We've got to find a solution to this healthcare shortage, and it's not just healthcare, but healthcare is a huge concern for us, obviously, and we're going to talk about long-term care. They're struggling with the same things. Until we find a solution to that, I see more services having to be cut because of financial constraints and financial pressure in all of our communities. There's big conversations going on in every one of our communities, and these just might be the first dominoes to fall before we get out of this.
Senator Hutchins, you have a question, ma'am. Go ahead. We can't hear you, Senator Hutchins. Sorry.
Sorry about that. More concerned about the
There you go.
hand than unmuting. Thank you, Mr.
You got them
Chairman.
both now.
Mr. Bowling, I can hear in your voice, and I think it's coming from your heart, how grim everything sounds. And the information you've just given us is, to me, heartbreaking. I'd like to know if there's any, and this just came to my head, any kind of thought in getting back all the nurses and doctors that left Wyoming or Cheyenne or Natrona County because of the COVID vaccine mandates.
Mr. Bully?
Mr. Chairman, Senator Hutchins, obviously that's something that we've thought a lot about. I think the thing to realize is the mass exodus that we expected to happen because of the vaccine mandate. We didn't really see that. There have been a lot of exemptions given, religious exemptions, medical exemptions. The numbers, especially in hospitals, haven't been what we expected them to be. And part of that is because there was a loosening especially in the exemption side of things. The area we've really lost a lot of these workers, though, is we've had nurses that quit to go become travelers because they could make 3, 4, or 5 times what they would make on an hourly basis, work for 6 months and take the rest of the time off. I don't know how to get them back. We are starting to see some of them now that the rates are, we're not paying 3 or 4 times what we used to pay hourly. Now we're paying 2 or 3 times. They're starting to come back to those communities, and I'm hoping to see some of that happen. But we've also seen through burnout, we've seen folks just leave the industry for a lot of different reasons. I think the area we really need to focus on, in my opinion, is we've got to figure out how to build new workforce and how to entice them into this industry. And we've got some ideas, and that's totally off the topic of what we're talking about today, but we've got some ideas I think that we'd like to explore as we start looking at workforce issues.
Okay. Further questions, committee? Go ahead, Senator Representative Stivar.
Thank you, Senator Baldwin, for the promotion. I really don't want it. The question I have is in the school and the training. I know I had a constituent call me that was in nursing school. She had an exemption. She's a CNA, had the exemption to be working, but was said she couldn't continue with her schooling because the way the nursing program works is they have to go out to this facility, this facility, this facility, and they had to get their exemptions from each facility. Have you looked at if they're in nursing school, they've got an exemption, they're already working in it, is given that exemption so they can all go, so they can continue?
Mr. Chairman, Representative Stivar. So I am aware of how the exemptions are supposed to work. CMS has come in with a pretty heavy hand. I was under the impression, though, that if the school had provided an exemption and they had a contract in place to do clinical rotations in a nursing home or a hospital, that those exemptions should be honored. I'd probably want to get a better idea of what it is so we could look into it, but it doesn't make sense to me that that exemption wouldn't be honored.
Follow up?
Go ahead.
Now, my understanding is I called a couple of the nursing schools. The schools are not given the exemptions. My understanding is the student has to go out and get the exemptions from each facility, the nursing home, wherever. In my case, what I was, the constituent I talked with was already a CNA that worked in a hospital, had an exemption to work in the hospital. And then she has having problems going out to finish her training because, you know, this nursing home here is not given any exemptions.
Mr. Chairman, Representative Stiver, I'd have to look at the example.
We need to.
Yeah, I'm
We'll talk
happy to
offline.
look
Thank
into it,
you.
work on it, because that doesn't make sense to me either.
Thanks, sir.
Further questions, committee? Oh, go ahead, Representative Zach. Oh, yeah, go ahead. You're done. Okay. Yeah, that's the two-hand wave. This means I'm done. Further questions, committee? Go ahead. Senator Furphy. Yeah, you can borrow.
Thank you, Mr. Chairman. Let me ask, how successful is the WWAMI program in bringing doctors back to our state?
Go ahead, Mr. Bowley.
Mr. Chairman, Senator Furphy, it's very successful. We have a high recidivism or retention rate. One of the areas that we've struggled a little bit is just, it seems like some of the students kind of go in waves where in subspecialties where we may not have enough demand for those positions, but we have a great relationship with the WWAMI program and place a lot of those students back in the state. But if they go into a subspecialty where there just aren't any of those services offered in the state, it makes it really difficult for us to put them in Wyoming.
And I would add on that the retention rate from WWAMI is extremely high.
Yep.
Extremely high. It's an extremely successful program. So yes, go ahead, Senator McEwen.
Thank you, Mr. Chairman. Just want to ask a question about the WWAMI program. Once the student enrolls in it, is there not a requirement that they have to come back? It seems like we might be running around the room high-fiving ourselves, but it's already a requirement. How many of those doctors stay after the requirement's over? Thank you, Mr. Chairman.
Go ahead, Mr. Bowley.
Mr. Chairman, Senator McEwen, so there is a requirement they stay for 3 years. However, if they get recruited by an out-of-state facility or provider that wants to pay that off, they can pay their loan back. And there is a requirement. If they don't stay, they have to repay that. We've actually seen where if we can get them to come back and work for that 3 years, there's a really high rate of retention where they set up a practice and like to stay in the state.
Go ahead, Senator McEwen.
In an organization I was part of for a long time, where we wore funky clothes that looked like camouflage. I talked to the chief surgeon when I was stationed overseas in a land that makes sausages and beer. His problem with doctors that they'd paid off their loans and signed contracts, and they decided if they wanted out, they could literally eat themselves out because they had to maintain height weight requirements and they booted them. You're probably wondering, how is this relevant? I think we have some doctors that we go through the WWAMI program and they get through it and they get their degrees and they're, like you said, they find places to buy off their contracts and they go. And I'm just curious, how successful are we really in the long term with the program? Thank you, Mr. Chairman.
Thank you. Senator Wassenberger. Welcome to the committee, by the way, Senator Wassenberger.
Well, thank you, Mr. Chairman. And so just a brief discussion on WWAMI. My son is actually a doctor in the WWAMI program, and he will return to Wyoming in approximately 3 months. From the date that he graduated from high school, he had 15 years of formal training. Currently in the state of Wyoming, our WWAMI program has right at, I think, 68% of its doctors coming back and finishing the 3 years that they are required to. Now, you need to remember that each one of the WWAMI kids, and if you remember Dr. Mook that was just speaking to us, the pediatrician, the young man that was sitting beside her is a brand new WWAMI student, and he starts July 11th. But those students have been incredibly successful at coming back. And yes, it is true that some of them at the end of their training are actually going to hospitals that pay out the loans that they have. Each student And I think my son Jory will have approximately $500,000 in loans. And that's a huge commitment. That's with the state of Wyoming paying tuition. Because obviously, when you're going to medical school, you still have to live. You have to pay rent, you have to buy food. And typically, those expenses are very expensive. Seattle's a very expensive school to live in. And so they have a huge debt without paying for the tuition. The state of Wyoming pays, I think, about $70,000 a year per student. So it's extremely expensive. But at the same time, they have to pay us, the University of Wyoming, I believe $12,000 a year each student. So they have $48,000 worth of cost just in the 4 years that they're in the program. Okay. We take that money, we put it into a trust fund. That trust fund pays for things. It's right now, I think about $4 million. That $4 million pays for things like lab coats, any equipment that they might need that they can't afford. And that's what that's used for. Of the students that come back, which is almost 70%, which is the highest that I am aware of in programs like this throughout the United States, 60% of those docs that come back, 60% never go anywhere but here. They come back to the state of Wyoming, they spend their time in the state of Wyoming, and in fact, you can go to their website. You can go to the University of Wyoming, go to the WWAMI website. There is a picture there of every doctor and where he works, what town and community he is in, or she. And of those doctors, there's communities in this state that if it wasn't for the WWAMI program, they wouldn't have a doctor. In smaller communities, one of them I just drove through to get here, has, I believe, 4 WWAMI docs there right now. And so I would encourage the committee down the road to, and I'll be long gone. I've got about 6 months to go and I'll be gone. But I would encourage this committee to support the WWAMI program.
And at this point, I would throw in a shameless plug for the Witchy program, which is not just talking MDs and DOs and PAs, but we're talking about a lot of our optometrists, our dentists, our physical therapists, et cetera, are going through the Witchy program, extremely valuable program. And you'll hear about it because we have to pay dues to belong to that organization, but they pay off in 100-fold. They're huge programs and they're a big deal. These programs are often confused with the residency programs in Wyoming, which is a totally different matter. We can discuss that in depth some other time, but with that, any further questions, committee?
Mr. Chairman, I would just reiterate, I mean, in a lot of our communities right now, PAs and APRNs they're the lifeblood of healthcare in our communities. So between the two programs, we're very fortunate, and it's helping us fill the need. We still need more, obviously, and we need more that want to do family practice, but we're big supporters of both of those programs.
And there again, another plug is that it's not just a Wyoming problem with family practitioners. That's a national program. It pays more to become a orthopedic surgeon, for instance, than a family practice. It's hard to get people to go into family practice. That's trying to be fixed nationally, but it's not fixed yet. It's still a problem. Okay, thank you very much, gentlemen.
Thank you.
Okay, let's do this. Let's break for lunch and we'll come back and take, oh, go ahead. Oh, if we got anybody that wants to leave right after lunch and wants to do public comment, we can take some of that now, both here in person. Let's talk about in person first. Do we have any public comment that wants to come down and that's leave? We'll do more public comment after lunch, but let's get what people have to leave. Let's go ahead and come down now. Show some handouts for the committee. Oh.
My name is Bonnie Katz. I'm from Powell, Wyoming. I'm not here representing a specific organization, but I do serve on the Powell Hospital District Board of Trustees. I am currently the chapter chairman for the Wyoming chapter of Postpartum Support International. I do serve on the Perinatal Quality Collaborative here in the state of Wyoming, and I'm the immediate past president of the International Childbirth Education Association. All that to say, I'm not new to this field, and I'm a little bit passionate about what I'm about to talk to you about. I would like to suggest that we look at reimbursing doulas for their services. For those that don't know, a doula is a non-medical provider. A doula does not do any type of healthcare advice or healthcare procedures. Now, I've been a doula for about 25 years. I'm also a registered nurse. But when I go into a room as a doula, I do not take anyone's blood pressure. I don't take anyone's pulse. I don't do any medical tasks because that's outside the scope of practice for a doula. And right now I'm specifically talking about birth doulas. There are postpartum doulas that help moms or families after the baby's born. But I'm specifically talking about birth doulas, and typically in their practice, they will see a mom several times during pregnancy. They will be with her throughout her entire birth experience, and then usually do 1 or 2 postpartum follow-up visits. What a doula does is provide physical, emotional, and informational support for women and families as they're going through childbirth. And just think about it, any kind of crisis that you go through, whether it's a positive one like planning a wedding, or a rather sad one like the loss of a loved one, you handle it better when someone walks through that crisis with you. And that's exactly what a doula does. Many of the things that we've talked about here this morning, a doula has an impact on: prematurity, the cesarean rate, mental health. All those things are things that a doula helps with. I just gave you some numbers here about the cesarean rate because that's the place where you're going to see the most immediate, most dramatic return on your investment. And that's what it is when you reimburse a doula. It's a return on an investment. It is going to lower the cesarean rate. I'm taking these numbers from a study that was done. It's a meta-analysis. They brought together 26 different studies from around the world involving more than 15,000 women from middle and high income countries. Doulas, and when I say that, it means people that were trained in birth to help women in this way. So Grandma Sally can't come in and call herself a doula. We're talking about people who've been trained. They lower the cesarean rate by 39%. That's a significant decrease. And I'm not going to read the numbers on here. I think you all can take a look at those. I will say when I started in this work about 30 years ago, the cesarean rate had climbed to 24%. And we were outraged that 1 out of 4 women had to have a major operation to have a baby. Dr. Neil Shaw, who is a Harvard-trained obstetrician and still works there in that area, is working really hard to reduce the cesarean rate in the United States, which, by the way, is 32.8%. It's now 1 out of 3 women. So comparatively, Wyoming does very well. But you will see on the references on the back of this handout, one of the general information things that I have listed there for you is the video by Dr. Shaw. Our cesarean rate has increased since the 1970s, but our outcomes have not improved. That's something to seriously consider. We're doing more surgeries. Cesareans are now the most common surgery in the United States of America. But our outcomes are not showing any difference because of it. Doulas, relatively speaking, are cheap. If you'll notice here, I've given them a pretty healthy stipend, $1,000 per birth, which when you go to compare, you'll see is much more than any other state is currently offering. The reason being, in most places, doulas aren't going to, there's not going to be enough babies born to make it worth their while if we don't give them a very healthy stipend. Right now, there's 2 states that fully reimburse doulas, Minnesota, which reimburses them out of Medicaid funds, and Oregon, which reimburses doulas out of Title V funds. I'm not going to tell you how to do that. I really just wanted to give you the information today to put this on on your radar. They're a great way to help reduce costs, not only immediately with the cesarean rate, but as you can see at the bottom of the page, with fewer interventions, that's a lower cost right off the bat, but fewer premature babies. And we've had people talk today about right now, when we have a preemie, we have to ship them out of state. That's pricey. APGAR scores lower than 5. Those APGAR scores tell us how well a baby is doing immediately after birth. Those babies typically need more intensive care. And then a higher breastfeeding rate. We know that babies that are breastfed tend to be healthier. When they get sick, they tend to be not as sick, and they tend to not be as sick as long. And that's also healthcare for mom then too, because the longer a mother breastfeeds, the lower her risk of any kind of reproductive cancer. So breast cancer, cervical cancer, uterine cancer, all of those are lowered the longer mom breastfeeds. So there's not only this immediate return on your investment for investing in doulas, but also long-term ones that I won't even try to quantify the cost for. That's all. Thank you.
Questions, committee?
Mr. Chairman.
Who said that? I'm Representative Slitner. I saw you and I don't know if that was your voice.
Mr. Chairman, it was not my voice. That was Representative Connolly. But I do have a quick question. I've led a very sheltered life, obviously, because this was a term I was completely unfamiliar with in a field. It's fascinating. How many of you operate in Wyoming, and what might be the standard care of cost and the length of, your term?
There's a variety of doulas in Wyoming. I won't even try to give you a number because we're scattered out. Some are certified, most are not. Most have some kind of training, but to be certified is pricey. It probably costs about $1,000 for the original certification. Most organizations require recertification every 3 or 4 years, and most of them require 20 to 25 hours of continuing education. So that's, again, part of the reason why the healthy stipend that I've offered here on this estimate, just because to keep that certification up is going to be pricey. That's why many doulas in Wyoming are not certified. They've had training, but they don't pursue the certification because it doesn't make financial sense. Typically in Wyoming, and it depends greatly on where you are. If you're in one of the more rural areas, you might charge as little as $400. If you live in Jackson, you can charge significantly more. So it really just depends on where you are.
Follow up, Representative?
Yes, sir. Thank you. So then do you does the patient enter into a private contract with you as a doula? And then I know you said there are different types of doulas, pre and post care. How long might your service with that patient last? Is it dependent upon what they can afford to pay you?
And I do want to modify that a little. Most doulas that I know operate on a sliding scale. If they feel like you really can't afford it, they will find a way. Many doulas barter. And I'm sorry, I'm going to have to ask you to repeat that question.
Mr. Chairman, I just was curious if you did answer it, I suppose. It would just be, I was just curious how long that care might last.
How long? That's right.
How that interaction, how long the interaction.
Thank you. Most of the doulas that I know will visit with a mom at least twice throughout her pregnancy. Some do much more than throughout the entire birth process. So from the time mom calls until usually a couple hours after the baby's born, and then they follow up with at least 1 or 2 postpartum visits.
Representative comment? Nope. Okay, now that I can see you. Dr. Hallinan, go ahead, sir.
Thank you, Mr. Chairman. And have you made this presentation to Blue Cross Blue Shield?
I have
Because they
not.
would have the same savings if this thing is accurate.
You're exactly right. They would. I think that's a wonderful idea and I will take that.
And thank you, Mr. Chairman. If I may, just one further follow-up.
Go ahead.
I'd say that, don't the nurses provide this kind of thing in the hospital, in the delivery room?
That's a wonderful question and one that I get very frequently. Nurses and doulas, their job descriptions do overlap, but they are somewhat different. Again, doulas don't do anything medical, but a good nurse, if she's taking care of a woman who it's her first baby and she's at 4 centimeters and labor's just kind of moving along, but then somebody walks into the ER and it's her 4th baby and she's at 8 centimeters, what's the nurse going to do? She's a good nurse. She's going to prioritize her tasks and go take care of the woman with the more immediate need. The difference between nursing care and doula care, and this is in that study that I mentioned, is that doulas provide continuous support, and they've found a significant difference in continuous support versus intermittent support. So nurses are great providers of support. I in no way do I want to discount the care that a nurse gives, but doulas only take one client at a time. She doesn't leave that woman. She doesn't work a 12-hour shift. The longest birth I've attended was 27 hours. It was a marathon. I didn't work a 12-hour shift. The nurse did. And that's not an insult to nurses, because I really don't want a nurse taking care of my clinical care when she's been on duty for 24 hours already. So I'm not trying to insult anyone. I'm simply drawing their parallel duties, but different in how they perform those.
Further questions, committee? And I would just interject here because the hackles just raised on the back of my neck. When we're discussing nurses, it's not necessarily she.
Oh,
There's a
excuse
lot
me.
of male nurses and I have been there.
Yes,
So I think that's an important thing for everybody on the committee and in testimony, but that's just my personal hackles.
I appreciate that. Thank you.
Thank you very much for your presentation.
Thank you. I appreciate your time.
Is there anyone else here in the room that won't be able to be back after lunch that needs to testify now? Come on down. And introduce yourself and go ahead and speak to the committee.
Mr. Chairman, my name is Rebecca Smith, and members of the committee. I'm the director of the Wyoming Women's Foundation. We are a nonprofit in the state, and our mission is to help women achieve economic self-sufficiency and provide opportunities for girls. And we're housed at the Wyoming Community Foundation, which is a statewide resource for nonprofits in the state. So I'll try to be quick because I know I'm standing between you and lunch. But our primary interest here is in that women have the ability to stay in their jobs and go back to work as soon as possible, as soon as they want to, as soon as they need to after giving birth. And so we're really interested in women being able to participate in the workforce. And so that's the angle that we're taking on this issue. And so I know that everyone else before me has given some great testimony on the importance of prenatal care and women's access to it. And I kind of wanted to echo that and provide some ideas on how we might address that issue. So I think it's clear that we need to incentivize prenatal care rather than disincentivize, or even the status quo that we're doing right now, where we're not really disincentivizing, but that we're seeing a decrease in women accessing prenatal care. And so some ideas for that would be to add pregnant women to the priority populations for community mental health centers. And you can reference the 2021 HB 38 on those priority populations. And then I also wanted to bring to your attention a Montana law that was passed in 2019 under Senate Bill 289 that protects pregnant women from criminalization if they seek prenatal care and they're using substances. I'd also just add to the previous support for more funding for our mental health centers and those beds that are set aside for women that are parenting. And then I would also ask for you all to keep this on the agenda for the upcoming meetings for this committee so that we can continue exploring some of these options. And then because I probably won't be able to comment after the next agenda topic, I just also wanted to put in a plug for extending that postpartum Medicaid benefit and just bring to the committee's attention that although there is some overlap between the first two agenda items and that item, it is broader than just serving women under that are using substances, right? We heard from the Department of Health that 50 to 75 Medicaid born children have the substance use withdrawal, but there are over 2,000 Medicaid births, right? And so just keeping in mind that it's a separate and broader topic than that, and that those women are really needing that care to be able to, beyond 60 days, to be able to get back into their lives and know that their children are safe and that their health is taken care of as well. I'll stand for any questions.
Questions, committee? Okay, thank you very much.
And Mr. Chairman, if I might add, I believe you received a handout from LSO, but if anyone would like a hard copy, I can pass that out with some of the topics that I talked about.
Pretty good. Committee can grab those on their way down here. As soon as we're done, if you just put them right there in the end of the table, we'll get. Okay, committee, is there anyone else in the room that won't be able to come back after lunch? See none. How about the online folks? Any of those folks? Okay. Oh, we'll double check. If you're online and you can't come back after lunch, raise your hand. Dr. Haggie, let's admit him and let's hear from him, please. There he is, Dr. Haggie. We see your friendly face. If you can hear us, go ahead and unmute yourself and introduce yourself and go ahead and speak to the committee. Can you hear us, Dr. Haggie? Well, Dr. Haggie disappeared. And he's back. Dr. Haggie, if you can hear us, go ahead and unmute and go ahead and speak to the committee. Technology can be a wonderful thing. Shake your head if you can hear us, Dr. Haggie. Well, you disappeared again. This makes me miss those days of no technology for committee hearings. Okay. Okay. Let's do that. Oh, he's back one more time. We'll try one more time. Dr. Haggie. Oh. He's like a magician. I think he's in the wrong meeting. Okay, let's go ahead and break for lunch and let's contact him and see either if he can come back this afternoon, we can solve it, or if he can provide that for us later. Thank you very much, by the way, Mr. Brody. Even though you're a trader and going to leave us, we appreciate your help. Okay, committee, let's break for lunch. You've got until 1:15. Reminder, the cafeteria next door is open today until 2 o'clock. Tomorrow they will not be open. So if you have a hankering to eat over there, you got to do it today. Okay. Tomorrow, it could be anything else you can find in town. So we'll be back at 1:15. Thank you, committee.